Good morning. I had a question, Liz. Did you take attendance for last week or have you not looked at it yet?
I haven't looked at it yet, but it will be on Canvas.
Okay, I just wanted to make sure that I didn't get missed.
Yep, you are good. Everyone that's on Zoom, it prints me a report of people's participation. So if you were present, then you are good to go.
Great, thank you.
Mm-hmm. All right, we're going to give it another minute because there are still several folks that we're waiting for. We've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Okay, well, that's almost everybody. So we're going to get started here in a moment. Share screen. I guess got really quiet. So nice. All right, so a couple of things. First, the exam. So Dr. Sweeney emailed me over the weekend and asked me to open it this morning. That way you have an extra week to work on it, and it will still be open through the 29th. I'm not sure exactly why the change was made. I just do what I'm told, but you have an extra week to do it. Same exact format as the midterm. It is only going to cover the second half of the course. It is not cumulative. He did tell me that if anyone would like a cumulative exam to let us know, and we would be more than happy to give you one. I feel like that's unlikely. And then the correct answers will be posted on the 29th at 11:59 p.m., just like last time. If you did the bonus, I will add those 5 points to your exam score unless you don't need a whole 5 points, in which case I will add them to your midterm or split them in between or whatever. If you did not do the bonus, too late, sorry. That's why it's bonus. Oh, no worries. I saw it and I was gonna respond, but I was like in my car and I'm like, we're gonna talk about it. So good on you for being on top of things though. Yeah, I just made the change yesterday when I got the emails. I'm like, all right, cool, let's do that. Any questions about that? Folks, go ahead.
So in the midterm, you have the system of the answer the questions one at a time, as opposed to scrolling through. I don't know as well, but it's a long time to go questions.
Okay.
Like a significant amount. I think it's just because there's so much data.
Yeah.
And so I was wondering, I don't know if it would make more sense to have it in a scrolling format or if there's a way to like work around that. If that was just
you're actually not the first person to talk about that. And I think especially because people have different internet speeds. And I think that that's a reasonable request. So I can do that. Yeah, let's do that right now while I'm thinking about it. No, I think that's totally fine. In the past, because people have different internet speeds, and especially if you're doing it at home and not at the school and so on and so forth, and that definitely affects the amount of time that you have to take it. So let's do that right now before I forget. And then
Liz,
if you have, go ahead.
Can you repeat the question that was just asked in the room? I'm sorry, I missed it.
Oh, you're fine. So the question was whether or not we could put them all the exam questions on one page as opposed to one per click because of the extra time it takes to load in between, which I am fine with, because that is something a few people have brought up, is just like if you don't have as fast of an internet speed, that becomes a thing. Show one question at a time. Bye. Bam. See, that was easy. Cool. And then if you have DAS accommodations, they should already be there. I repeated everything from the midterm. If it's missing or if I forgot or if I messed it up, let me know. But double check on that and let me know ASAP. So today we are also going to review the last set of case studies and then some of the information we didn't get to last week on medication-induced diagnoses, and then ethics and legal issues, etc. I did add some Oregon specific information to Canvas when it comes to legal issues and ethical issues. That will not be on your exam because your exam is based on the textbook only. But I put it on there because I think it's important for all of you to know, presuming that you're going to be working in Oregon in a year or so. So we'll talk about a little bit of that as well.
I had the question about the 3 hours, Liz, is that?
So it'll be 3.5 hours.
About the test, is it, if we're in the middle, so 3.5, can we pause and take a little break in the middle and then come back, or does the timer keep ticking once you start the exam?
I don't know. Does anyone know? Did anyone try to pause on Canvas? I'll find out.
I got kicked out of the test in the middle. The site went down, and so then I had to log back in. My website was fine, everything was fine. It's just Canva kept spinning and spinning and spinning, and then kicked me out. So, and it took a while to get back on, and I didn't know if I lost time because of that, and was just wondering if for future tests, if I could take 3.5 hours is a long time without taking a quick restroom break. So I was just wondering if it was possible to pause and then come back.
Let me find out.
Okay.
Yeah, I will find out and shoot out an email. And then someone had asked too about if you already have an A, doing bonus. So the bonus is really there for people that aren't doing as well. If you have, an A- or below, go for it. But if you already have an A or an A+, don't. Yeah. All right. Let's see. So case studies, all the open tabs. let's talk about Christopher. What did folks think about Christopher? Too much. I did have one person submit a question that kind of made me laugh because it was relevant. Did everyone see the newer Joker film with Joaquin Phoenix? Oh, okay. Well, somebody was like, does he become the Joker? And I'm like, well, maybe. So what diagnoses do folks think are most relevant for Christopher?
I think Tourette's disorder.
Okay.
And depressive disorder due to another medical condition. So both of those is what I would choose for this person.
That makes sense. So the Tourette's disorder, because he's having multiple types of tics, it's ongoing. It appears to get worse when stressed. He meets all the criteria. The depressive disorder appears, he reports being depressed, but we would also want to get more information and see if he meets the full criteria, but most likely, if that's what he's reporting. Did anybody add any of the V codes that we talked about last week? No, and that's okay, right? So just like in the field, they're not really required, but if you want to, go ahead, Savannah.
Just speaking of the V codes, I had another type of class. I had to add something like that. I don't know if it would really apply to this case, but there was one that was parent-child relational problem. And for my assignment, it was for an adult who's having that problem. Is that appropriate or does that have to be an actual child?
I would use it for either, honestly. The DSM doesn't specify if it has to be an adult or a child. So you could use it for children, you could use it for adults, any of that. So the question was about using the parent-child relational problem V code.
I didn't think of that because he's having problems with his family.
Yeah. Yep, you could absolutely add that. You could add a code about issues, one of the employment-related issues or occupation-related issues, all that stuff.
I wondered because it almost, I actually put down, I put down schizophrenia because this drug at the end is, I guess, can be used for schizophrenia. So I wondered if he's been treated for all this stuff for Tourette's, it's not working. So I wondered if that was in there at all.
So I don't think he meets the criteria for schizophrenia because he doesn't actually talk about any sort of positive symptoms. He doesn't report any hallucinations, any delusions. He doesn't appear to have any negative symptoms. And you're correct, haloperidol or Haldol is an antipsychotic. Unfortunately, historically, so this is in the 50s, right? Haldol came out, Thorazine was in the 40s, Haldol came out, say late 50s, early 60s. And as with all of these other issues like ECT and insulin shock therapy, all of those things, they were often used for things that weren't psychosis. So don't let that information fool you. You will get lots of clients who are older adults who have gone through these sorts of treatments, including antipsychotic medication, who do not have any sort of psychosis, because at the time, that is what we did to people. So let's be grateful that poor Christopher did not get the lobotomy, which is actually sort of surprising, because at the time that was also a thing. Nothing else is working. Let's stick an ice pick up there and scramble things around and see what happens, right? And you will have folks that have survived this. What's that? It's not illegal. It's not illegal. It's rare. Ice pick lobotomies aren't a thing anymore, but there are some procedures in very extreme cases where folks will still have surgical procedures. It's not very often in Oregon. What's more common now is that medications are used to induce similar effects, but actual surgical, at least the preorbital prefrontal lobotomy is not considered best practice. But I have had several clients that have had similar procedures done who are older in the prison system at the state hospital, that sort of thing, because they've been around long enough to have experienced those things.
So Liz, I was wondering, with this case study, like you mentioned, back in the 50s, 60s, when haloperidol was an experimental drug, has it been proven to be helpful for people with Tourette's now at this point? Is it something that's commonly prescribed for Tourette's?
Nope. Haldol is an antipsychotic, and that's pretty much it. It's a very, very effective antipsychotic, but it's not something we would use for Tourette's now. Tourette's treatment now tends to be, there's not a lot that you can do for the underlying actual neurological tic, but often medications that help with things like agitation or stress will be prescribed to help keep the tics at a baseline. Let's see. Another one that came up, and only a few people actually put this one on their list, was a potential head injury because of the hitting. And it doesn't specify here whether the hitting was hard enough to induce some kind of injury, but we do see that some of the tics get a little worse after the fact. So that might be something to rule out. And again, you know, this is the 50s, and so we're probably not doing fMRIs because they don't exist yet. But if you had a patient like this now, you would definitely do some kind of, you would refer them for some sort of imaging to see if there's injury, or if there's kind of a before and after the head hitting, which is also a thing that you'll see, especially in hospital settings. People will bang their head on the wall, they bang their head on the window, all that sort of stuff to kind of try to get their symptoms to stop, which ends up with a head injury, and then things sort of get worse that way. Marvin, let's talk about Marvin. What did folks put for Marvin?
I had adjustment disorder with anxiety. But I also tried to rule out anxiety disorder.
Okay.
I felt like he met the criteria of the significant impairment, but I wasn't sure if the first part, the distress out of proportion, like if that definition is based on what the therapist thinks or what the client is reporting.
And that is a great question, because you will have people develop distress to things that are distressing, right? Which makes sense. Like Marvin's having a really, really, really rough time. So it really comes down to what the client reports, and what would be considered the norm. So we know that it is normal to be distressed over something like an HIV diagnosis, right? What I would consider to be out of the norm is if the person becomes so distressed and it's been a year since they got the diagnosis that they stop doing everything else, right? They're so distraught that maybe they've stopped going to treatment. Maybe they've, quit their job. Maybe they're no longer, maybe they're just staying home in bed all day, all that kind of stuff. And those are things, again, depending on the diagnosis that they've gotten, that might be a reasonable response. I probably wouldn't use the anxiety due to medical condition, because we don't have an etiological link between HIV, AIDS, and anxiety itself. So there's nothing about the actual HIV virus that induces anxiety in the brain. It doesn't it doesn't increase sympathetic response, things like that. You might put something, but it makes sense, because when we say due to, we're like, oh, of course he's anxious because he's got AIDS. Who wouldn't be? But when we use any sort of mental condition due to another medical condition, what we're really saying is that there's some sort of medical link that the medical issue causes, right? Which is confusing. But,
so if you have it like due to another medical condition, that's only medical, not mental disorder?
it could also be mental disorder.
Can you say what they said?
Yeah, so the question was whether or not you could, if the anxiety condition due to, or an anxiety disorder due to another medical condition, if it just had to be medical, or if it could be a mental health disorder as well. And the answer is it could be both. A better way to look at it is mental disorder due to another diagnosis. But again, there has to be that etiological link between the other diagnosis and whatever the mental disorder you're diagnosing is. Did anybody put anything other than adjustment disorder? I did get a few other answers on the actual submissions. If anybody would like to speak up and discuss why they put something else?
I said illness anxiety disorder.
Okay.
Now I'm wondering about that, but that's what I said.
So what criteria do you feel like Marvin met for illness anxiety disorder?
That he was, seeking care for, although I guess like reading it again, I guess it's the seeking the psychiatrist. I was also thinking that he was seeking other doctors too.
Well, illness anxiety disorder would make sense because all of his testing shows that his HIV has not actually developed into AIDS. But right. He does report all of these other symptoms, and he's starting to go, he's having issues about this disfigurement. He is just starting to become really dependent on others, like the illness anxiety. He's starting to come up with symptoms that aren't necessarily related to the HIV. And he is worried about it developing into AIDS, even though it hasn't actually. So he does meet the criteria for illness anxiety disorder. I would probably ask more questions too, like, okay, is he on medication? We don't know what year this is, which is kind of on purpose, right? Is this 1989 or is this 2022? Because in 2022, we know that somebody with HIV could get on medication and do perfectly fine. And then those anxieties might be considered out of proportion. Whereas if it's the early 90s and we don't have great medications yet, but based on just the information we have, the intrusive thoughts, these beliefs about disfigurement, all of those sorts of things, that could qualify as illness anxiety disorder because he doesn't actually have AIDS yet, right? If he did, like if we checked his viral loads and if we saw that he had actually developed, full-blown AIDS and wasn't just carrying the virus, or if it had gone far enough that he did develop AIDS and his viral load was high enough, then maybe we would not consider that to be out of proportion. But because he hasn't, we could consider that to be out of proportion. The irony, though, too, is that fatigue, sore throat, headaches are all symptoms of HIV. So, often the first signs, especially like GI issues, all of those things are usually what sends a person into testing because they're suddenly having these flu-like symptoms that can be a sign of HIV. But all these other things down here, the fact that he's not attributing those to HIV, the fact that he's attributing those to the autoimmune deficiency syndrome, AIDS, is what could make it illness anxiety disorder and not that.
So are you saying the best answer is adjustment disorder?
Either adjustment disorder or illness anxiety disorder or both.
Okay, thanks.
Yep, he meets criteria for the adjustment disorder because all of these issues down here. He meets the criteria for illness anxiety disorder because all of the issues up here. Mm-hmm. Yep. They don't give us enough information. Yeah. So that would be, you could say that he doesn't meet the criteria because we don't actually know how long, right? And it doesn't tell us that these issues up here have stopped. So my presumption is that if it's been going on long enough that it's causing all these issues, that it would meet the criteria, but you could absolutely make that argument that he doesn't meet criteria just based on the amount of time. But it doesn't give us a full Mark. What do folks think about Mark?
I had gambling order, persistent and severe.
Okay. So gambling disorder, persistent, severe. Any other thoughts about Mark?
I had some feed codes on it.
Okay.
I had other problems related to employment, so the V6229. Mm-hmm. Problems related to lifestyle, mm-hmm. and then relationship distress with spouse or intimate partner.
Okay. Yep. Any other appropriate codes or diagnoses for Mark?
I couldn't hear. What did they say?
Gambling disorder, severe and persistent. Any others?
I have a question on
yeah.
Like one of like the questions I've asked would be like what medications taking for that ulcer.
Yeah.
And like how often experiencing that flare up. And then I also was wondering, it just randomly says that he's disbarred in Montana. And I guess I was assuming that he's in Oregon now. So I'm like, okay, is this an extra distress where now he's the job in the second state?
Yeah. Yeah, those are all great questions. So the questions were about what kind of medication he's taking for the ulcer. And I'm assuming that the question there would be, is he having these issues with wanting to get up and move around, which are some of the things we'll talk about today, and if that's due to the medication, which is a great question. And so you would want to know, like, are you getting up and moving around because it's helping, with the pain, or are you getting up and moving around because of your medication? And then the Montana versus Oregon thing. Yeah. I mean, if he's lost multiple jobs, I think just losing one job, or embezzling from your current job would be enough to meet the criteria. But those are definitely questions I would ask, just, if I'm treating Mark, like, how long has this been an issue? If you were disbarred in another state, it also speaks a little bit to, how, why we do things like background checks when you're getting licensed in one state versus another, because we didn't used to. So that's a thing. Randy.
I feel like I'm talking a lot today.
You're fine. You should talk.
I was kind of confused. I said malingering, but I couldn't tell if it would also be antisocial personality disorder with malingering, or like how that diagnosis would be written out.
Okay.
But I also couldn't figure out like what the benefit would be for the malingering. Like, I guess I'm just not familiar with that process of if you are found incompetent to stand trial, do you go into inpatient treatment? Like, I'm assuming they don't just let you off.
Yeah, so that's actually what we're going to talk about today. So first with diagnosis, you could diagnose both malingering and antisocial personality disorder, and you would just put them in order. Some people put them in order based on the actual number of the code. Some people put them in order based on importance or what they feel like is the most prevalent, all that sort of stuff. And we would need to do, so he's getting all sorts of testing here. We would need to do some additional testing for malingering specifically. So a lot of the testing that they're talking here, it shows that there's inconsistency, but that could be due to a lot of other things. And when we do testing for things like trial competency, we would actually specifically test for malingering as well, which is kind of outside the scope of this class. So a lot of the information that's in here is interesting, right? If you're reading a full psychological assessment of somebody, you're going to get all of the information, whether or not it's relevant to the diagnosis or not, right? Just like if you do a full psychosocial assessment, you're going to get the person's entire life history, but not all of that is relevant to the current diagnosis. So a lot of this one was trying to rule out other things. So we know that he's got some beliefs that are a little odd. He makes some statements that are a little odd. A lot of folks listed rollouts. Folks listed rollouts about delusional disorder, paranoid personality, even schizophrenia because of these beliefs. He doesn't really meet full criteria for any of those though. So we would probably list malingering as a rollout. As far as antisocial goes, because he's only 21, that's another one where you can make an argument yes or no based on how we don't see a lot of information about lack of empathy, charming behavior, frequent lying, all of that. We see some things that indicate or imply that he might meet those criteria, especially as an adolescent, but we don't see if he meets the full criteria now. Savannah?
Can you maybe point out those things that, like, because I don't remember picking up on any of those.
Okay.
And I felt that because there wasn't really a history of that, plus any, like, I know legal problems isn't a diagnostic
Yep.
But it's a sign of
Yeah.
possibility.
Yeah. So you could list the legal problems as like a V code, right? So the things that might imply antisocial are going to be, so the history of legal problems, yes. Frequent encounters with the law, yes. This sort of guardedness, the enjoyment of talking about his psychotic experiences, the fact that he would really sit there and think a lot about his answers. So there's a lot of implication here, but there's not a lot of actual criteria, is what we're getting at basically.
Did you say that it's sort of like a form of manipulation that's there?
It could be, and that's what we would want to get more information about. If he fully meets the criteria for antisocial personality disorder, we would definitely need to ask more questions. And some of this we would also want to see these things down here. We would want to get more information about that, because I've had patients that refuse to work with their attorney because they believe that their attorney's out to get them. We have and it's part of their illness. We have patients that are unable to work with their attorney because they're so sick that they don't even know what's going on. And then there are patients who refuse to work with their attorney because they do know that they can then be found unable to aid and assist and get sent to the hospital while they're waiting to stand trial. So it's a whole kind of thing. And we'll talk a little bit about what that looks like today with the ethical legal issues. So lots of rollouts here, lots of E-codes you could use here. Any other questions or thoughts about Randy? Not yet, cool. So that's it for those case studies. Bye. So we're gonna switch gears. We're gonna talk about, let me see here, it's 9:30. So let's talk about do you guys wanna do ethical legal issues first and then break and then do medication-induced disorders? Or do you wanna do medication-induced disorders and then break and then do ethical legal issues? Option A, nobody cares? Okay, option B, nobody cares, cool. So let's do the medication-induced. Well, no, let's do the legal stuff since we're already kind of talking about that. Anybody online have a strong preference, feelings, chat stuff? Yep. All right, so lots of people think malingering for Randy, which is fine. We would definitely want to do more testing, but that does appear to be the most likely scenario. All righty, let's go over here to legal and ethical issues. So again, we're going to focus on the stuff in your book, but we are going to talk about some Oregon specific things because I think you should know it. So mental health law, we're going to be looking at specifically civil commitments, criminal commitments, and issues around patient rights. And what that is really referring to is some of these issues we've talked about before around mandated treatment versus voluntary treatment, whether or not a person can really consent to treatment, give informed consent, all of that kind of stuff. At what point we can hospitalize a person without their consent, and then at what point somebody could be hospitalized due to criminal behavior, criminal responsibility, all that kind of stuff. So some things here to pay attention to. The legal definitions for a mental disorder don't necessarily match up with the clinical definitions. So lots of people meet, say, diagnostic criteria for depressive disorder, anxiety, all of those things. But depending on the state, the actual legal definition may or may not include those things. For example, in Oregon case law, we have very, very specific wording that is used, and I'm going to pull some of that up for you. It's also on Canvas about how we define a mental disorder in the ways that it impacts a person's ability to make decisions, proceed in court, all that kind of stuff. So you could very well have something like schizophrenia, but if it doesn't meet the legal criteria for whether or not your schizophrenia is affecting your behavior, whether or not it was the direct cause of, say, your criminal behavior, all that kind of stuff, not the same thing. Issues around dangerousness and mental illness. We're going to talk about that, how and when insanity defenses are used, and patient basic rights. So lots of things that are complicated here. You know, I'm going to open this so it looks nice. Ew. Hey. Whoa, where'd my mouse go? Shit. Where's my mouse? Where'd it go? Why is it doing that? Let's do this like that. Ah. Is my share screen still doing stuff for everybody online? Can you see the slides?
We can see the slides.
Perfect. Thank you. I don't have a mouse, so you guys are just going to be in the middle. So lots of things that need to be balanced here. And these are things that will come up in your workplace, right? So patient rights as an individual. Patients have the right to decline treatment. Patients have the right to give informed consent. Patients have the right to make bad life choices. Patients have the right to basically do whatever they want. If they don't want to live in, say, residential, they have that right. If they break the rules and get kicked out of residential, they have all of the same rights that everyone else does when it comes to things like housing, right? So let's say it's part of their lease that they can't use certain substances because they're in, say, a recovery type placement. They still have all of the same rights. You know, they have choices to make and rights around eviction. So they still have to go through the eviction process like everyone else, all of those things. And the same laws apply. Let's say somebody is in immediate danger. Let's say they assault somebody at their group home. They're going to have the same sort of emergent, the other patients there will have the same rights as anyone else, right? Just like if one of your roommates were to assault you, you would have rights and that person could be removed. So all of those same things still apply, because just because someone has a mental illness does not mean they don't get to, you know, have all of the same housing rights, that the other laws don't apply, all of those things. Savannah?
I've heard this before, just kind of wanted to know if this is true thing, but if somebody, like let's say they're in a residential program and they leave against medical advice, does that affect their future medical care or insurance or?
It shouldn't. So the question was whether or not if somebody leaves against medical advice, whether that would affect their future care or insurance. It depends on the type of program. So any one of you could go to a hospital and get up and walk out whenever you want, right? It could be against medical advice, but unless there's some sort of issue around informed consent, if you are so ill that you cannot give informed consent, that gets a little more complicated. But if you do have all of your capacity and you make a choice to leave, that's your choice. Whether or not it affects your ability to continue to get care, you can still get care, you will still have insurance. You might have to work with your agency and figure out, are they going to accept me back into this program if I've left, 3 or 4 times? But you still have all the same access technically that other people do. You would still be able to, they might have you sign like a behavioral contract or something depending on the agency, but legally you still have all the same access. Yeah. So individual safety. This is where we look at things like potential danger to self. If a person is actively suicidal, they have a means, method, and plan. It could also be whether or not they are at risk due to other patients. And oftentimes you have to very, very carefully weigh one patient's safety versus another patient's rights. You see this a lot, especially in residential settings and hospital settings, and different organizations will look at that differently. For example, at the prison, if somebody, and this is, well, not just true at the prison, but anywhere really, if somebody is actively a danger to them, to others, in Oregon, it is legal to do medication, even if they don't consent to the medication. And so in the prison, for instance, we might medicate somebody because they're extremely, extremely assaultive due to, say, their psychosis, right? because the issue is both security, safety of the institution and security, safety of other patients. If other patients are getting injured really, really badly, or staff gets injured really, really badly. But then you also have to weigh the rights of that individual, the one that's being medicated. So like an organization like Disability Rights Oregon, their job is to kind of gatekeep that piece. And so if you say like, hey, we're worried about this patient because this other patient B isn't medicated, and we're worried that patient A is going to get assaulted because patient B is targeting patient A, an organization whose job it is to pay attention to those individual rights for patient B, they're going to say, we don't want anything to do with that. Our job is to make sure that patient B isn't medicated against his consent. Whereas, administrative court, their job is to make sure that patient A is kept safe. So neither one of those is incorrect. They're both just doing their job. They're just doing their job from different angles. And then society's right to safety and security. So this is where we look at things like whether or not a person is committed, or whether or not a person, let's say a person is guilty except insanity, whether or not that person's safe to return to the community after their hospitalization. So
if somebody commits a crime and this is probably a dumb question, but if somebody commits a crime and they're found to not be mentally stable enough, or whatever their criteria is, when they're done at the hospital, is that just the end, or could they be transferred and incarcerated? Like if it was sexual assault or murder or something like that, are they done?
We're actually going to talk about that. That is a great question. And it is a very contentious issue in Oregon right now. So we are going to talk about that. So let's start with civil commitment. Civil commitment is when a person typically hasn't committed a crime, but this is a person who's very, 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 very sick. They are acutely, in Oregon, it has to be an active danger to themselves, an active danger to others, or gravely disabled. The definition for gravely disabled has shifted a bit because there are lots of things that influence civil commitments, like whether or not there are beds available. The state hospital, for instance, has halted all civil commitments because there aren't beds available, but you can still be held at, say, Cedar Hills or another hospital. It is contentious because, again, anytime you lock somebody up without their consent, you're taking away their rights. And so for a civil commitment to happen, anybody can petition for anyone to be civilly committed, right? If you're like, Professor Liz is nuts and we want her to be civilly committed, you can go in front of a judge and you can go online and submit a petition through the court and do that. And a judge is going to be like, okay, there's going to be tons of evaluations. Folks from the hospital or the actual placements are going to come and meet with me and see whether or not I meet the criteria that the state has decided on, so on and so forth. Typically, the most common way that we see people civilly committed in Oregon, at least, is if they have a guardian. And let's say the patient or the client is deteriorating really, really, really badly, and then the guardian can have them committed because the guardian can step in and do consent for them. So let's say the person isn't capable of giving informed consent. That's already been decided, which is why they have a guardian, right? And so the guardian then can hospitalize them if they feel like they need to be. But if they don't have a guardian, the criteria are much more stringent. They have to be actively a danger to themselves, actively a danger to others, or gravely disabled. There are lots of people that clinicians we might consider to be gravely disabled, but that the law might not. For instance, my 73-year-old lady that I've talked about a few times, where she, the family went to the home and found her waiting around in septic waste. In the state of Washington, they would not grant the family guardianship, because they decided, well, she's living on her own, she's able to make it to the store, blah, blah, blah. Whereas in Oregon, they did grant the family guardianship because, it took her getting charged with crimes, unfortunately, but they also were able to argue like, yes, she goes to the store, but it's because we have her trust account linked up to the store and the store just like lets her get what she needs and they send us a bill. That's not the same as actually being able to go to the store and do your things. But because she was still living independently, however unsafely, Washington did not consider her gravely disabled, whereas we did. So it just, the definition shifts. And it's very, very subjective. It's also purposely subjective because you want to have some sort of judicial discretion, because we want to avoid things like Fairview. We want to avoid things like where we are, institutionalizing people willy-nilly because the family finds them inconvenient or difficult or whatever. So in some states, just needing treatment can be used for civil commitment. In Oregon, that is the minimum. It is necessary, but it is not sufficient. They also have to have the dangerousness or the grave disability. The other thing that comes up a lot with inability to care for self is this inability to care for self completely on their own, or is this inability to care for themselves at a lower level of care? When you get out into your jobs, that is going to be the question that often comes up is, does this person, yes, this person has been committed, but do they need hospital level of care? Can we put them at a lower level of care, say residential or intense inpatient or something else, or like intense outpatient or a different type of program, so that we can balance their rights, right? Their right to not be locked up, their right to not be institutionalized with their need for care. So lots of things come up here. If the person doesn't have a guardian, the state or the county then gets to step in and act as guardian. We don't see this too often in Oregon. We see this with minors in Oregon. We don't see this often with adults. And with minors, it's typically a totally separate issue. Or a person who's IDDD, we might see this. But typically guardianship will be, Oregon is very, very strict on finding actual guardians rather than the state taking guardianship, but it is possible. You can get a public guardian. There are agencies where all they do is provide guardianship and you get a caseload and you are the guardian for your caseload. For instance, I had a patient at the state hospital, a lady who had a history of very, very, very severe depression to the point where she had become catatonic. When she's doing well, she does amazing. When she's not doing well, she stops eating for months at a time, becomes gravely disabled because she's literally starving to death. And so the guardian had her civilly committed. They ended up having to do ECT with her. And after a couple rounds of ECT, she was back to baseline, back to normal. And then when she's back to normal, the guardian could still say, no, you have to stay here. No, you're going to go here or go here. But because she was back to baseline and doing well, she worked with her guardian to decide, where am I going to live after the hospital? And there's still a whole process for that. So like those of us at the hospital, we have to do a reassessment at certain timelines, which we're going to talk about. With civil commitments, it's every 30 days. Every 30 days, you're reassessing that person, saying, is this person still so ill that we can justify taking away their freedom, right? So every 30 days, we're looking at harm to self, harm to others, grave disability, and we're remeasuring that every 30 days. Once they are there, I believe it's 6 months, then instead of being every 30 days, it's every 6 months. So the timelines change over time. It's a whole kind of thing. And again, you don't need to know these for your exam because they're organ specific, but just so you're aware. Involuntary medications, that can be every 6 months, whether or not they still need the medication. So let's say the person gets better right away and they're suddenly consenting, they're still going to be considered involuntary until they have their next hearing. All kinds of legislative stuff there. So if this patient in particular, she worked with the guardian and she's like, I want to go to a group home. And then because she has the guardian's the one who has to sign all the consent and everything, but the patient got to make that decision. This is a public guardian who again has a caseload and works with lots of people. So they know that system really, really well. That's kind of an ideal scenario. You do have folks whose guardians will disagree with them about what they need. And if they've been appointed guardianship, they get to make those decisions.
Liz, in your experience, does this system work well? Just from a spectator position, I feel like it's hard to imagine the government actually being able to thoughtfully manage anything. And then it doesn't seem very well balanced with society's right for safety and security. So
Yeah,
it's complex.
It is very complex. And we're going to talk a little bit too about kind of the history of institutionalization and this sort of pendulum swing. So it used to be that we would just warehouse people and they had no rights whatsoever. And there was no process to make sure, you know, that they were actually being fairly institutionalized, you know, at the expense of their individual rights. Whereas when we deinstitutionalized, the pendulum swung the other direction. And now, and this makes sense philosophically, right? You can't lock somebody up because we think they're going to commit a crime. I mean, think about the ethical implications of that. We can't lock somebody up because they look like they're about to commit a crime. We often have to wait until they actually do. You know, you can't arrest somebody because they look shady, even though that happens. Technically, you can't arrest somebody because they look shady. However, once they commit a crime, you can. And that's how it works for everybody, right? Not just folks with mental illness. And that's where the civil commitment process becomes useful, because if a person expresses that they are going to commit a crime and it is due to their mental illness, then yes, you can go for civil commitment, but it has to be violent, right? If somebody says, I'm going to go break into a building or whatever, that doesn't really work. It can't just be a property crime. It has to be an actual harm to self, harm to others. Savannah?
Does it ever happen where, like, if somebody was wrongfully committed, like there wasn't a good enough reason, that they would sue them?
Oh, yeah. Oh, yeah. People, so the question was if folks get wrongfully committed, if they then had some sort of, you know, civil action they could take. And the answer is absolutely.
How would they prove that, though? You know?
So that is why we have such strict laws, especially. So Oregon, the legislation here is very, very specific. And there's a very specific legal process a person has to go through before they can actually be committed. And it is to prevent situations like that. Those lawsuits aren't typically successful because if they've gone through that process, it's going to be considered valid commitment. But on the off occasion, you know, let's say you have somebody who's super duper malingering and then later they're like, JK, you wrongly committed me. They might have grounds to go on. Let's say they weren't tested for malingering and we just assumed that they were mentally ill and then we lock them up when they haven't done anything wrong. They could then go back and say that, and they could sue on the basis of, well, you didn't actually test me for malingering, right? I've never seen it happen, but hypothetically it could happen. You will have patients tell you all day long they're going to sue you for putting them in the hospital because people are upset because they're hospitalized. And they've gone through the whole process, so it's pretty unlikely, but they could try. There are, that's where other sort of kind of watchdog organizations like disability rights come in, because that's kind of their job, is to make sure people aren't being wrongfully committed. And then if they are, they typically handle those kinds of cases. There's also an issue right now, like with the states, if people are considered to no longer need hospital level of care, the state law isn't clear that the hospital can hold them. So the judge has to say, no, they don't, you know, we have a whole process for determining hospital level care. That's every 30 days for certain types of commitments. But the law says that we then have to find an alternative placement if the county doesn't accept them and we continue to hold them at the hospital against their rights. That becomes a whole other thing. So that's kind of a current legislative issue that is being slowly addressed.
Liz, so it's harm to self, harm to others, or significant disability, right?
Yes.
So why do we have people who are homeless dying in their tents, or clearly having hallucinations and clearly hearing voices, and people who aren't able to care for themselves, even by standards of being homeless? Like, why is that? It sounds like they could be committed and get some treatment. Like, I don't want to lock up homeless people like that. I don't think that's the solution to the problem, but I'm curious about why people aren't getting help.
So that's a really big question. Any thoughts? Yeah, so that's one thing. The state hospital doesn't have beds, but not just the state hospital. There aren't beds across the state, right? And then things get further complicated. If a person declines treatment and they are deemed to be able to give informed consent, that's a big one. And that's where things get really, really sticky. Like I'm a little bit more paternalistic, I'll admit that. Or to me, I'm like, well, how can this person give informed consent or decline if they're so ill? But then there are other schools of thought that are much more sort of patient oriented that say, well, just because they're ill doesn't mean that they don't have capacity to give consent. And that's where things get really, really sticky. And, you know, how much of it, again, I struggle with this because I'm much more paternalistic about things. If it were up to me, we would have a happy bubble where everyone could go and be happy and like have a puppy and have a house and get the treatment that they need. And they would have the insight to know that they need the treatment and all of those things. Unfortunately, a lot of people don't have the insight to know that they need treatment. Maybe treatment has also been really traumatizing for them in the past. Maybe they have other barriers to treatment. Let's say they have a history of sex offenses, so they can't go live in a residential facility with other vulnerable people. Let's say they are actively using and they can't get into a program that doesn't accept folks that are actively using. There are all kinds of other barriers coming up. The next piece would be, let's say they're actively using a substance that induces psychosis. That's something we see a lot in the legal process. We can't say that somebody's guilty except insanity if it's like an amphetamine-induced psychosis as opposed to schizophrenia. Lots of issues there. So it's a whole thing. Because even in residential, people are still expected to pay for their rent, right? And it's usually income-based. So let's say you're on Social Security, you get $700 a month, you're going to pay a third of that for your rent. Let's say people don't want to do that. I've heard people straight up tell me, I don't want to give anyone my money. I'd rather live outside. And that's their choice. It might not be my choice and I might not agree with it. It might make me really, really sad. But that's their choice. So that's where the whole patient right thing comes into play, is that people have the right, you know, even if they're mentally ill, people have the right, just like everyone else, to decide, you know, what kind of treatment they want, all those things. If a person is actively ill, that's not the same as grave disability. So even though like Rebecca might see somebody on the street, or I might see somebody on the street and I'm like, holy crap, that person is so sick. Like that's really, really rough. But if they are feeding themselves, if they are surviving, the threshold for what we consider to be gravely disabled is really, really, really high in Oregon. So just being mentally ill, just experiencing hallucinations, so on and so forth, that is not considered enough to be gravely disabled. Inability to care for self or others. I have 2 master's degrees and make a decent amount of money. I can't afford to buy a house in Oregon. Is that inability, or is that our housing market, right? And so when we say this person is unable because they're homeless, is that because they are quite literally unable to maintain housing, or is it because they can't afford housing? And those are 2 different things, right? So if we look at inability, that would be a very literal inability. They cannot manage things like taking care of themselves. And the way to really look at that is, okay, let's say they end up in the hospital for a couple of days, they have a hold, they get evaluated. If while they're there, they're able to like shower and go to the bathroom and eat and do all of those things themselves, they are not considered gravely disabled. So the issue is a lack of access rather than a lack of ability, right? It's not a fun place to be in. These are icky topics. These are icky positions to be in. So, mental illness as a legal concept. Go ahead and take a look at some of the stuff that I posted on Canvas. You can see how they define things like mental illness, grave disability, and dangerousness to self or others. So again, the takeaway here is that having a diagnosis is not the same as being considered legally mentally ill. Typically does in Oregon, cognitive disabilities, it depends. So if a person is IDDD, just like everyone else, a person still has rights. And let's say they do commit a crime. Or let's say they are unable to take care of themselves because of their intellectual disability. The fact that they have an intellectual disability alone is not enough. It's going to come down to whether or not they can take care of themselves. Folks with intellectual disabilities tend to be one of the populations that have the least rights, because we tend to infantilize them, right? You might have adults who are intellectually disabled and maybe they can't hold a job, or maybe they can't do certain things, but we often have folks come in and act as guardians because we have that sort of kind of paternalistic view where we see people very childlike, whereas with mental illness, we do less so. Substance-related disorders, this is another one that is kind of the opposite direction, because you could make an argument as clinicians, we see that as an illness, right? We see any kind of addictive disorder as a disorder. This person is ill. However, let's say they have a substance-induced psychosis. That's probably not going to be enough to get them committed. Because our culture, we still see substance use less as an illness and more as a matter of personal choice, as opposed to taking a more clinical dialectical approach where we can say, yes, this is both, right? And in Oregon, having a substance use disorder does not qualify you for disability. Being in recovery from a substance use disorder does. So there's all sorts of cultural, political things that happen. So we have some flexibility here. The issue is that this does make us really vulnerable to bias. So again, we see certain mental illnesses as being sort of worse than others. Folks with schizophrenia, we tend to see in more paternalistic ways than say folks with really, really intense depression or anxiety or PTSD or another type of diagnosis. And a lot of that is because of historical bias, all of those things. There are also programs that are considered to be contraindicated with certain types of diagnoses. For instance, Assertive Community Treatment Act, which is a crisis response team. If you have borderline personality disorder, you do not get ACT services in the state of Oregon, because the assumption is that every time you have a crisis, you're going to use this resource, and it's not a real crisis because of your personality disorder, which is problematic. Let's say you have somebody who's actually harming themselves or they're suicidal. And they don't have access to that service. They have access to other services, but they don't have access to that particular program. So there's lots of things here that can be vulnerable to bias. Dangerousness. So we talked about this a little bit in the past. So obviously every single person who has DID, very few people with DID are gonna look like the guy from Split, right? No one's out there just like kidnapping and torturing people because of their disorder, right? If they are, it probably has a lot to do with other issues in addition to their disorder. That being said, it does happen. There is a moderate increased risk, and this depends on the nature of the disorder. If I'm schizophrenic and the trees talk to me, but they're telling me that they're unicorns and that I'm a prophet and that life is great, fine. If I'm schizophrenic and the trees are talking to me and telling me, you know, go murder so-and-so, that's different. If I'm schizophrenic and the trees talk to me and they tell me go murder so-and-so, and I'm like, hey, that's my hallucination and I know how to cope with that and I have the skills to cope with that, I'm going to ignore it, that's different. If I'm schizophrenic and the trees talk to me and tell me to go murder so-and-so, and I'm like, yeah, fuck yeah, the trees told me to, and then I do it, that's different. So again, just having the illness, not enough to make somebody dangerous. It depends on the nature of what that person's actual hallucinations, delusions are. There have been a lot of contentious cases. I worked with Larry Moore for a while. He was the first mass shooter in Oregon. He was the Salem Tavern shooter. There was a news article about him 2 years ago where they were revisiting that case. So this is all public info, so I can share it. He is very, 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 very ill. Larry, in his current situation, he is housed in special housing at the Oregon State Penitentiary. Again, public information. He is not okay. He is practically catatonic. He is very, very sick. At the time of his crime, they evaluated him for guilty except insanity. He went and shot up the Salem Tavern because he believed that they were poisoning him and they were trying to kill him. And so it was very clearly linked to this specific delusion. He heard voices. He meets the full criteria for schizophrenia. You can read about it in the papers. At the time, they decided that the judge decided that because as he was committing the shooting, he made eye contact with one particular person, skipped over him, continued to shoot. The Oregon statute says that if the person knows right or wrong, if their illness doesn't keep them from knowing right or wrong, that that's not guilty except insanity. That's how that was interpreted at the time. Now we would interpret it as, okay, yeah, he has schizophrenia, but his delusion didn't include that particular person. It wasn't a matter of he knew that it was wrong to murder people and that's why he skipped that person. Now we know, okay, it was a matter of his delusion. He just thought that person wasn't one of the people poisoning him. You know, he will be incarcerated until he dies. Mm-hmm.
I mean, halfway, it's just a question too, but with developments in like the mental health world, like the new DSM, like things are always being updated, and I don't know when that happens.
Yeah.
I'm familiar with that happens. But do you ever go back in the system and be like, hey, with the new information, like this is no longer like the correct process, we should change this?
That is happening all the time, and it's actually being brought up in our current legislative section. Or legislative session, but a lot of that isn't just because of clinical information. A lot of it is because of things like funding and bed space and capacity and all that kind of stuff. So in order for that to happen, somebody would have to file an appeal on Larry's behalf and have a judge agree to re-sentence or retry him. Instead of being adjudicated guilty, he would have to be adjudicated guilty except insanity, and then he would have to go in front of the Psychiatric State Review Board and be placed elsewhere. The thing that also makes it complicated is that this happened 30 years ago. Schizophrenia gets worse over time when a person doesn't get good treatment. And so we can't say, there are lots of people that are extremely, extremely ill that are in prison, and maybe now they'd be better off at the state hospital, but when they were sentenced, they were actually doing pretty okay. So that's the other issue. If they're not guilty except insanity at the time of their crime, they're going to prison. But let's say they're there for 40 years and now they're really, really, really sick. That's, you know, that's where they ended up. So that is kind of an ongoing problem.
I think the language that we use around that is really interesting. The word insanity is so antiquated and has so much stigma attached to it. And you think it has to be this hysterical person like banging their head against the wall and, you know, slicing themselves open and, you know, and that's just not necessarily the case.
Yeah, absolutely. In Oregon, it's interesting that we do still use the phrase guilty except insanity. There are other states where it's guilty because of insanity. There are other states where they don't use the word insanity at all, but yeah, we use very, very antiquated language. And a lot of it is because of that historical context. So predicting violence, risk assessments. We don't use the PCLR, also known as the HARE, too often because that is measuring psychopathy. We use it in certain instances. If you're a PO or if you're doing a full assessment, you might use it, but we don't tend to use it to predict actual behavior because it predicts personality traits. There are lots of other assessment tools, however, that are used to predict violent behavior. One of them is past behavior. So at the state hospital, for instance, every 30 days, we say, has this person made a threat? Have they actually harmed someone? Have they made a threat with the means and method to carry out the threat in the past 30 days? Yes or no? Have they threatened to harm themselves? Yes or no? Have they threatened to harm themselves and they have means and a method? Yes or no? Have they actually harmed themselves? Yes or no? And there's also deeper questions about that. Did they give themselves scratches or did they actually slice themselves open, right? All of those things, if it's considered a surface injury, self-harm behavior, non-suicidal self-injurious behavior versus suicidal self-injurious behavior. All of those are the types of questions that we ask with assessments. There are also specific risk assessments that are done, and these are usually done by licensed psychologists that have different measures. We have measures that look specifically at violent risk. We have sex offender measures that look at risk. Yeah, those all exist. You don't need to know what all of them are for the sake of your exam, but I can post some on Canvas if people want to see what they look like. I know everyone wants to do tons of extra reading finals week. But you can also save them and read them over the summer, because who doesn't love reading sex offender risk assessments during summer break? You know, that's why we go into this field, because we like light, happy beach reads. Definitely. So restrictions on involuntary commitments. These are things that have been done in response to mass institutionalization and locking people up. OPB did a really, really amazing short, like 45-minute long documentary on Fairview that you should all watch. It's on YouTube and on the OPB website. So insufficient grounds to commit, just needing treatment. So Rebecca's great question about, you know, you see these people that are out there that are so clearly ill and so clearly suffering, that is not considered sufficient grounds for civil commitment. The gravely disabled one, according to your book, is insufficient. In Oregon, it is. Answer your exam questions based on your book. Just like when you get out and take your licensure exam, answer the questions based on your textbooks and ideal world with all the resources in the world. Don't answer them based on real life. That's what we were told for ours. So, what are the negative consequences of that as a result of, you know, again, the pendulum has swung. We don't just lock people up anymore for being ill, you know, but now we have people out on the streets and they end up in the system because of things like trespassing, theft, minor crimes because of their illness, right? Or because they are homeless and they don't have money, or because they're hungry, really basic things. Sometimes it turns into, we get a lot of menacing charges at the state hospital. We get lots and lots of trespassing, lots and lots. Menacing is the big one, because that's the person that's in your face and, you know, waving their arms around, or they're threatening. We get misuse of a weapon, all sorts of things.
You seriously have people who are committed to the state hospital for trespassing?
So we're going to get there. If somebody is found unable to aid and assist, and there's no other placement available, those people usually aren't going to stay at the state hospital, because they get there and we're like, they're not a danger to themselves, they're not a danger to others, they don't need to be here, let's find them a better placement. But you will have, and I've worked with officers that have even said, like, I've run into this guy, you know, 3 times a day for the last 2 months, and he can't get treatment because he doesn't meet criteria. So we're going to slap a charge on him because it's the only way to get him the help that he needs. That's kind of this monstrous system that we've created as a result of deinstitutionalization. Does everybody know what I'm talking about when I say deinstitutionalization? Okay.
Can you actually define that? I mean, my understanding is that there isn't room and the rules changed, and so fewer people with mental health problems are getting institutionalized. Is that what it means?
Kinda. So that's what's happening now, but deinstitutionalization as a process started to take place in the 70s and 80s, early 90s, and really finished off during the Reagan era, where we did huge cuts to social services. So first there was this issue of, hey, it's inhumane to warehouse people in these awful conditions because of their disability or because of their mental illness. But then it turned into, you know, screw these people and we don't want to pay for it anymore. So in the late 80s, early 90s, you see tons of people, all of those institutions are closing because of funding. And so you see all of these people ending up on the streets. The ideal, so when this process started, the ideal was, hey, we don't want these people to be locked up in warehouse in terrible conditions. Let's get them back to the community and get them community services instead. Let's get them into group homes. Let's get them into other residential facilities, even if it's a secure residential facility. Let's get them into supportive housing, you know, all of these other levels of care that don't have to be a hospital. But then again, during the Reagan era, they basically closed all of the institutions, but never funded the community aspect. And that is, we are still seeing, there's lots of legislation from that era that we are still seeing having effects now. Especially more so in states like Oregon, where we don't traditionally fund social services at the level that other states do. So lots and lots of folks end up on the streets. Lots of folks end up in other institutions like prisons because they're on the streets, and so they end up getting into trouble. Lots of folks end up in nursing homes because of things like alcohol-induced early dementia, stuff that we talked about with neurocognitive disorders, all of those things. There's been a lot of backlash, as you can imagine, especially from families. For instance, I had a client at the state hospital who She was banging on her parents' door, her father's door, begging for a gun to shoot herself, but the county did not consider her a danger to herself because even though she was suicidal, she was often suicidal and she didn't actually have access to a weapon. And they were like, well, she's got a plan. She's got a method in mind, but she doesn't have the means. Therefore, she is not actively a danger to herself. She ended up at the state hospital, unable to aid and assist for a myriad of other misdemeanor charges. That's a problem, right? And the family's like, this system is broken. She should have been hospitalized based on her mental illness and the fact that she was so distressed, right? But the county's like, sorry, doesn't meet the criteria. Go ahead.
So I'm wondering, like, you said that the means was the issue there.
Mm-hmm.
So it kind of made me think of, you know, when like in schools, for example, there's signs that a kid might be a mass shooter.
Yep.
And they evaluate, they do an assessment on, you know, the risk.
Yeah.
Do they look at needs in like I mean, for both situations, in like a very strict, or like a uniform way, or?
That's a great question. So the question was whether or not if we're assessing people for things like violence, for instance, mass shooters at school, if there's a set criteria for means, and the answer is no. Because if that person had gotten, say, a different judge, they might make the argument, well, maybe she could go jump off a bridge. But that particular judge was like, well, she specifically stated shoot herself. She doesn't actually have a gun, so sorry. To make things further complicated, that person, in addition to her psychotic disorder, also has a personality disorder in which suicidality is kind of a main component. So anytime she gets upset, she's like, fuck you all, I'm gonna go shoot myself. And we're like, well, you're at the hospital, so you're clearly not gonna go shoot yourself. And that's how she expresses her anger. So you also have to look at things like that. Is this person genuinely suicidal, or is this person staying this way, saying this because they're upset? And if they had a gun in their hand, would they? That's where the question gets sticky, because there are lots of people, we know that things like personality disorders and impulsivity leads to things like suicide. We also know that one of the biggest risk factors for suicide with a firearm is whether or not the person has access to firearms. That's one of the main arguments right now for restrictions on firearms, because we know that the number one risk factor for suicide by firearm is whether or not the person has one, whether or not there are firearms in the home. If the parents have firearms, we know that that vastly increases the risk for suicide among the kids. Oregon is also struggling right now with some legislation around whether or not police can legally seize your firearm if you are suicidal, because you have, you know, folks that believe that you can have a firearm no matter what if you have no criminal history, and other folks who believe no, because this increases risk of suicide, and whether or not a person has the right to commit suicide. All of those are sort of big questions.
I have done some training on suicide, and one of the statistics that I found is that, I might get this a little wrong, but you'll get the idea that like 50% of suicides happen within 5 to 10 minutes of the original thought. So like,
yeah, the impulsivity piece and the access piece is huge.
And so you can't wait. Like,
yeah,
you don't have the luxury of waiting and seeing. Like, it's like, if they're having those thoughts, then like that's has to be taken seriously.
Yeah, absolutely. Yeah, things get really, really complicated. So this backlash from caregivers, this is where we see folks petitioning for guardianship. And again, it's going to depend on the state, it's going to depend on the county, it's going to depend on the judge, whether or not that person can get guardianship and what is it going to take for them to get guardianship. Again, in the past and with certain populations, guardianship is much easier to obtain, for better or for worse, right? Criminal commitments. So in Oregon, there are a few different routes for this. There is ORS 161.370, which is inability to aid and assist due to mental illness. That is our folks, those are our folks who are found to not be trial competent. So this could be any kind of charge, misdemeanor, felony, you name it. The actual 370 order, however, and I can find some of these and post them online, will say whether or not this person is dangerous and if they actually need to be committed to the state hospital, or if they can participate in what we call community restoration, where they stay where they're at and they get their trial competency services in the community. This can look different. So let's say the person is trial incompetent because of their mental illness, and we do legal skills training, and now they're trial competent. They might still have the mental illness, obviously. So the mental illness doesn't go away, but now they're trial competent. Let's say they are experiencing some sort of, drug-induced psychosis, and that goes away. The evaluation that they undergo is not necessarily whether or not they are still mentally ill. It is also whether or not they are trial competent. Both of those are taken into account. So these evaluations are done by certified forensic evaluators in the state of Oregon. It needs to be a licensed psychologist or a psychiatrist. It's usually a licensed psychologist, and they have a specific format. So they do a full psychosocial history, they do a full diagnostic workup, they do testing for malingering, and then they do actual legal skills training. Do you know the name of your attorney? Do you know the role of the judge? Do you know what you're charged with? All of those things. So in Oregon, they have to have a diagnosis, and they have to be found trial incompetent. They need to have both. Those are evaluated in Oregon. When a person first is found trial incompetent, their first evaluation is within 90 days. After that, it is every 6 months, with the caveat that they have to be doing treatment. Let's say you have something really stupid like a trespassing charge, and you are found trial incompetent, and you start with community restoration because you're not dangerous. But let's say you don't attend any of your appointments, or you aren't able to attend your appointments, or there are other barriers in the way of you getting the treatment you need to be found trial competent. There's a good chance you could be revoked and sent to the state hospital for services there. Let's say you are found to never be trial competent. So this was a question that Rebecca brought up earlier. Depends on the type of charges. In Oregon, if you have a misdemeanor charge, we have 1 year to restore you to competency. We cannot hold you more than 1 year. If you have felony charges, that goes up to 3 years. Sometimes the judge will check the little box where they change that amount of time. The actual legal language says whichever is greater. So it could be the maximum amount of time that that person would be incarcerated, or 3 years. Where things get sticky, let's say that you probably committed a murder. We don't know for sure because you aren't trial competent, so you haven't gone to trials. And you hit your 3 years and you are still not trial competent, then you could be committed under Oregon ORS 701.426, which is involuntary commitment for extremely dangerous persons due to mental illness. This is when, and there's all sorts of evaluations that get done. This is for a person who we have really, really good evidence that they probably committed the crime, or they continue to be extremely, extremely dangerous. So this is my fellow who, because of his dementia, went in and strangled somebody at the group home. Because of his dementia, he was never found trial competent. And also because of his dementia, he was deemed an extremely dangerous person because he continued to do things like wander into other people's rooms. That's going to look different than, say, the person who committed a crime and they are found trial incompetent, or they are found trial competent, but then they are adjudicated guilty except insanity. That's a totally different process. That means they actually go through trial, or if they choose not, that you can opt. In Oregon, you can opt for a trial, or you can opt for just doing it with the judge, right? You can decide whether or not you want to take your case to trial. You can plead guilty. You can plead guilty except insanity, and then choose whether or not to go to trial. There's all sorts of stuff that you don't need to know because it's not in your book, but so that you're aware. If that happens, let's say the person is found unable to aid and assist, and then their trial competency is restored, and they go to trial, they're not found guilty except insanity, they can still go to prison. If they're found guilty except insanity, they are under the jurisdiction of the PSRB, the Psychiatric State Review Board, and they usually start at the state hospital and then they go elsewhere. A lot of the work that we do at the state hospital is also, helping people make good choices. So you can parrot back legal skills and tell us who the judge is, who your attorney is. But we also evaluate for things like whether or not the person truly understands or if they're just parroting back, right? And that's the difference between people who really understand the evidence against them versus people who are so ill that even though they can tell you the legal definitions, they don't actually understand the process. They don't actually understand the evidence, all that kind of stuff. Sometimes the work here is like, okay, you were found trial incompetent. You could be held at the state hospital for up to a year, but maybe you do have some really stupid charge like trespassing that if you were not trial incompetent, this would be dismissed or you would be put on probation or whatever for a month or 6 months. So that's where things again get kind of icky ethically. And that's where people in the community have to decide that your CMHPs, your community mental health providers, those are your big agencies that decide, does this person need to go to the hospital? Is this the only way we can get them treatment? Are we going to lock them up against their will because of a really stupid charge if it gets them the treatment that they need? Or are we going to advocate to get this charge dismissed so they can go back to living their life? And that is often sort of it's a group decision. You make those decisions with your care team, but it does get really, really sticky.
It seems like people are almost trying to go back to the old system. They're just trying to find workarounds where, oh, we can't, they're not a harm to themselves or others, but kind of like they were saying, the police were saying that like, we've seen this guy all the time for forever and he needs help. So we gave him a trespassing charge. And now, you know, like, it just seems like people are trying to do an end run around like the new rules almost.
Absolutely. Yeah. And that is often the case, but it's sort of both, right? Because of deinstitutionalization, we see people picking up charges just because of the nature of being out on the street. And we do see systems where they think the person needs help. And so that's the only way they can get them the help they need, which is really, really sad and awful. Ideally, there are 7 layers of care, 7 levels of care rather, in the United States, ranging from regular outpatient, I have depression, I go to therapy, all the way up to inpatient hospitalization and all 5 in between. Ideally, every state, every county would have at least one facility or program at each of those levels of care. And ideally, whoever is evaluated or whoever decides that they need each of those levels of care would then consent to doing that level of care. The reality is that people don't. And so you have lots of people who, and this is where that whole kind of argument is, and there really isn't a great answer. There's the whole, again, individual rights versus individuals' ability to take care of themselves and having to balance those two. The insanity defense plea. So this is a legal statement in Oregon. So your textbook says not guilty because of insanity. In Oregon, we call it guilty because of insanity. Those are interchangeable. Or guilty except for insanity is Oregon, GEI. The defendant will be sent to a treatment facility instead of a prison. A person can plead GEI for something like trespassing if they really want to. They probably won't, because then they're going to get the maximum number of years, you know, like why would I take GEI and get stuck under the PSRB for 3 years when I could just plead, you know, no contest or take a plea deal and end up on probation for a year and be out in the community. People have all sorts of reasons for making those decisions. Where we do see this is for charges that are a little longer. In Oregon, it's typically felony A's, things like arson, aggravated murder. Sometimes we see it with things like manslaughter, all of that stuff. Once again, having the diagnosis is not the same as being considered legally insane. Lots of people have diagnoses, and just like with our friend Larry Moore, very, very ill. Everyone knew he was very, very ill, but he did not at the time, the judge at the time felt he did not meet the criteria for guilty except insanity. So.
Is it possible that if they get sentenced to prison, even though they really did need hospitalization, if their behavior escalates or something happens, do they ever change that?
Nope. So the question was, if they are sent to prison and things change and they need hospitalization, do they get to go to the hospital? The answer is no. because they have been sentenced. We do have folks that are dual jurisdictions. Let's say they're in prison, but they commit another crime while in prison and they're adjudicated guilty except insanity for that crime. Then the judge has to decide, do they stay at the prison? Do they go to the hospital? The reason for that, the justification for not sending them elsewhere is that lots of people get sick in the prison, right? Lots of people who aren't mentally ill get sick in the prison and they still serve their prison sentencing. That changed a little bit during COVID. We did see a lot more folks. There are different authorities, like the governor can have people discharged early. There are mercy discharges, all that kind of stuff. If somebody's terminally ill, a lot of states don't do that. It's an individual kind of case by case basis, but most states, like you could have cancer, but if you tortured and murdered 4 people, you're still going to stay at the prison. And that's the reality of it. And there are lots of ill people in the prison. And that's why, at least in Oregon, we have multiple layers of care. So we have special housing, we have mental health units, we have day treatment units, we have intermediate care housing, which is where I spent a lot of my time, which is for folks that have a mental illness and because of their mental illness are not able to function in any other unit. So they don't do things like they do their meals on units, they do all their activities on units, they get weekly treatment as opposed to monthly treatment, all that kind of stuff. We have the mental health infirmary, which is really outdated language. Those are the folks that are, that's considered the inpatient hospital of the Oregon Department of Corrections. Those are folks that are immediately a danger to themselves or others. We have the behavioral health unit, which is the folks that do something really egregious. And instead of going to the hole, they go to the BHU instead. All sorts of levels of mental health treatment are available. It's not a great system because, again, you do have folks where as they age, they get sicker and sicker and sicker, and maybe they would be better off at the state hospital. But once they are adjudicated one way or another, we don't go back and change their sentence unless they go to court and get resentenced. So guilty except insanity, this is not super common. To me, it's super common because I'm at the state hospital and that's what I see all the time. But realistically, it's not super duper common. You see it in movies, doesn't happen a lot. Lots of history here. And you see this in Oregon stuff here too. So does the person have the ability to distinguish right or wrong? Yes or no? Is it due to their illness? Yes or no? And that's what we saw in the Larry Moore case. And then was the crime a product of the mental illness? Yes or no? So lots of people are mentally ill, but they might commit crimes that have nothing to do with their mental illness. So I had another individual at the prison who was very, very ill, and he went and shot up a clinic because he was mad at them. He, as opposed to Larry Moore, who shot up the tavern because he had a delusion that those particular employees were poisoning him. Both people have a mental illness. Both people committed a shooting. One was due to the mental illness. The other was not. Although technically, I guess Larry Moore's wasn't because that's what the judge decided. But all of us clinicians who work with him think that it was due to the mental illness. Yeah. I can be mentally ill and go murder somebody. And if it is not because of my mental illness, I'm still going to prison because I murdered somebody. And that's what happens when we murder people. If I murder somebody because I am convinced that they are part of this like conspiracy and it has to do with my schizophrenia, that's different. So the legal standards are knowledge of right versus wrong, self-control, whether or not there is impulsivity linked to their mental illness, and then diminished capacity. Diminished capacity has all sorts of different definitions depending on your state. In Oregon, we look at whether or not the person has capacity to understand the true consequences. So this might be somebody who, I had a client at the state hospital who stabbed his wife to death, and he does not remember any of it. He was considered to have diminished capacity because at the time he did not see his wife. He was hallucinating and he thought she was something else. Another example of diminished capacity would be something like, I stabbed her to death, but I didn't think she would die. I thought she would come back to life because she was a demon or an angel or whatever that person's hallucinating. All of those kinds of things. Knowledge of right versus wrong could be things like I thought that they were coming after me because I was hallucinating a demon. And so to me, that felt like self-defense, as opposed to I was mad at them, so I shot them, despite, having the mental illness, all that kind of stuff. Self-control is part of the American Law Institute standard. We don't see it come up a lot in Oregon. Yeah. So consequences. Savannah?
This part of it made me think of I won't get into it, but there was a case where a woman was being, I guess, like they were considering the insanity plea, and her diagnosis was kind of fuzzy, so like they weren't really sure, but you know, it would have really impacted the defense.
Yeah.
So is it often difficult for psychologists to be unbiased when they're making these evaluations because they know about the crime that happened? So if they, you know, maybe they heard of a really terrible crime,
yeah,
they instantly, oh well, this is obviously the, you know, the not an insanity, but
no, they're very specific. So if you are, because you have to be, in addition to a licensed psychologist, you also have to be a licensed forensic evaluator or certified forensic evaluator. So the question was whether or not there's a lot of bias with guilty except insanity. And your job is to know all of the charges, and your job is to know detail by detail. And so if you are a licensed psychologist and you're doing that GEI evaluation, you're going to go through detail by detail of the crime with the person and figure out how much of their mental illness had to do with what was happening at the time. And you're also going to look at things in the police report. Like, does the police say, and I see this a lot in police reports, well, they will say this person was incoherent. This person, you know, you're going to have that evidence from the very beginning. What that person's behavior looked like at the time of arrest. You're going to get evaluations from the jail at the time of arrest. You're going to get evaluations from the hospital at the time of arrest. All of those things are taken into account in addition to the interviews that you're doing with that patient. John Hinckley Jr., everybody knows who that is? Anybody? So, murdered, famous murder. President?
The guy who killed JFK?
No, attempted murder of President Reagan.
Yep.
Oh, right.
One of the servicemen.
Yep. So this came up just within the last few years. I don't remember which year because I don't know what year it is right now because COVID and time isn't real. We live in a vortex. But he was recently up for potential discharge. Because if you are no longer considered dangerous, you don't have to stay at the hospital. You can go out to something like a group home. In Oregon, typically we go from the hospital to a secure residential treatment facility, and then you get reevaluated. You can go to a residential treatment facility. Some people can go out and, you know, live a normal life. They're still under the jurisdiction of the board. So they still have to comply with things like treatment, taking medications, so on and so forth. But John Hinckley Jr. was up for that a couple years ago, and everyone freaked out. Because it was such a politicized issue. I had a case at the state hospital, actually, the fellow who stabbed his wife to death. Tiny town, tiny county, judge went to high school with the wife, the PO refuses to do their job. It's a whole thing. And we're like, this guy's fine. He was very ill at the time. He's medicated. He realizes that he is ill and that he has to be on medication forever. Before I left the state hospital, we had submitted this gentleman for discharge to a secure residential multiple times, and the county just refused because they didn't like the guy. And we're like, but he no longer needs to be at the hospital. We are keeping this person essentially incarcerated. Yes, he did this terrible thing, and he's no longer, you know, he's no longer needing this level of care. Other issues came up, like family pursuing guardianship and misusing his funds and living in his house and so on and so forth. So the guy also has nowhere to go. And we're like, this is kind of sketchy. So you have to look at all of those things, right? So with John Hinckley Jr., despite how politicized that case was, you know, if your job is to work with that individual, if you are working with a high profile case, you still have to do your job regardless of the public conception. It is still your job to do your evaluations, to decide, help determine what level of care they need. And if the public doesn't like it, too bad. If they're a public danger, that's a whole different thing. If they're a public danger, you're figuring that out as part of your assessment, right? You're going to be doing all of that work. You're going to be doing all the risk evaluations, that kind of stuff. Yeah. So it's not used very often. Most people end up getting the treatment they need. There are some cases where the person gets treatment and punishment. So these are your dual jurisdiction cases. For instance, I have had an individual at the state hospital where she had multiple charges of arson, manslaughter, so on and so forth. She was adjudicated guilty except insanity for one of the charges and found guilty for one of the other charges. So things get complicated. When she is up for her discharge from the state hospital, because she's no longer a danger to herself or others, she will go to prison because she still has to serve her sentence at the prison. That is a thing that can happen.
So is it up to the judge really how that works? Because it sounds like, if I'm hearing you correctly, some people might be released to the community and some people might go to prison to finish their sentence.
It depends if they are sentenced to prison in addition to. So if they are just found guilty except insanity on all their charges, it's not up to the judge at that point. At that point, they are under the jurisdiction of the PSRB, the Psychiatric State Review Board, and they decide where that person goes next. If they have multiple charges and they are found guilty except insanity for some of them, but just found guilty, regular old guilty for the others, then not only does the board, the PSRB, have jurisdiction, the Department of Corrections also has jurisdiction. So then when they leave to go to a lower level of care, it would be to the prison. If they still have a sentence, if their sentence is concurrent. So let's say you get GEI and that is for life. Let's say you get a life sentence, guilty except insanity for murder, but you were found guilty for arson, 25 years. You come to the state hospital, we evaluate you. After a couple of years, we're like, this person's no longer a danger. They don't need this high of a level of care, but they still have, 20 years left on their sentence. For the other charge, they're going to go to the prison for the rest of that time. So it's not really a get out of jail free card. And they're still going to be under the PSRB for life. So dual jurisdiction. This is a chart from your book. It's kind of a meaningless chart. This is how people feel about the insanity defense and how, it's mostly a meaningless chart because it looks really, really exaggerated because it doesn't go up to 100, it just goes up to 20%. And all of you have taken research methods and know how that works. So one fix to this problem is that we have specific courts that address things. So we've been talking about really, really, really serious charges, really serious cases, but what about the person who steals because they're hungry or because they're confused or they're disoriented? Or let's say they get charges and it's not due to their mental illness, but they also have a mental illness. A lot of counties in Oregon and across the country have mental health courts. So let's say they're stealing because they're homeless and they need food because they're hungry and they're mentally ill. The two aren't necessarily related. So we're not adjudicating them guilty except insanity for, theft one, but we're saying, okay, this person has a mental illness and maybe they're going to be on probation for theft, but we want them to go and get specialized probation. So they're going to go through mental health court. The judge might sentence them to treatment. Some counties have mental health POs as opposed to regular POs, which is great. Like Washington County has a whole mental health probation officer team, and their whole job, they have to be master's level clinicians. So their whole job is to do probation and parole for folks with mental illness so that they're in a separate sort of parole probation system than everyone else so that they can get those needs met. Some counties have drug and alcohol court, which is not regular court. So you get a DUI or you have an ongoing substance use issue, you go through this court instead, and maybe your sentencing includes things like having to go to treatment instead of just jail. Diversion court is an example. Everyone knows what diversion court is, right? You get a Dewey and you go to treatment and it's your first Dewey. So you go through treatment and then it gets dropped off your record. Those things can still be problematic. Like I have a client right now who got a DUI. It's his first DUI, but because he has a felony from when he was like 19 for cocaine possession, which he's been in recovery from since then. He was selling cocaine because he needed money and he was 19 and made bad choices. But he got a DUI now. because of that felony at age 19, which was, gosh, like 12 years ago or whatever, he doesn't qualify for diversion court. So we're trying to argue that he should qualify for diversion court because it's a different substance. This is his first DUI and he doesn't actually meet criteria for alcohol use disorder. So you do have a little bit of discrepancy that you can use here. Go ahead.
How different is it when there's a minor?
The juvenile court system is totally separate. So every state is different. In Oregon, let's say you would go to Oregon Youth Authority, and that is completely different than Department of Corrections. If you go to Oregon Youth Authority and you have a serious mental illness, you're going to go down to Children's Farm Home in Corvallis, and that is inpatient treatment. So
if it were to be like aside from crime, but just in general, they needed to be.
Oh yeah, yep.
Parents would have to say, or
yep, the parents or whoever the legal guardian is, and in those cases, they do tend to get institutionalized more often because they have a parent or legal guardian doing the thing, and multiple levels of care, right? So you would still have to do a whole petition and have a judge still say, this person needs to be hospitalized. Typically, you can do like a 3-day hold for evaluation, and then the judge would have to look at like, what are the evaluators? What are the counselors and folks at the hospital saying versus what the parents are saying? And there's a whole kind of process for that. It's messy.
I had a kiddo that I worked with who had been in foster care. I think he had been in foster care since he was like 5. Like if you want a case study of the system really not serving somebody, this kid would be your person. But so he was in the custody of the state since he was little, and as he got older, he had more mental health symptoms that came up, and the state institutionalized him. And so he was in psych res, and then they sent him to McLaren or Hillcrest, and the way he was treated was awful. Like he had mental health issues. He was suicidal. Like he really needed support, and they would punish him by making him sit on a concrete block for like 8 hours at a time if he had bad behavior. And it's like, that is not therapeutic. Like he was in the mental health unit. You would think that they would have more trauma-informed care there, but like by the time he got out, we managed to get his charges dropped, and eventually got him, to be able to be under his own care. But the kid system can be awful. Like I've seen kids and they institutionalize them. They get set up on their meds, they start to stabilize, and then they let them out, and the kid goes right back to what they were doing. And so like this whole thing was really for nothing.
Yeah, we see that a lot with youth that are in the system. That is definitely a very, very big problem. So determination for competence to stand trial. We talked about this a little bit already, whether or not the person understands their charges, if they are able to aid and assist. That is if they are willing to work with their lawyer, or if their illness is affecting their ability to want to participate at all. Burden of proof is always on the defense. So the defense attorney needs to submit this person. They need to put in a motion and say, I want this person evaluated for trial competency. They do all that. Some consequences here. So if a person is deemed trial incompetent, that is an issue, right? When a person is deemed trial incompetent, they don't get to make changes to their legal case until they have their fitness to proceed completely restored. So you'll get clients who, let's say they've been determined unfit or unable to proceed in courts. They don't get to do things like fire their lawyer and pick a new one and things like that until they have that decision-making capacity restored. In Oregon, we don't really see this affect informed consent for treatments. That's different. So this person still gets to choose whether or not they want to take medication, unless it meets certain criteria for certain types of charges. So there's a case, Cell versus the state of Oregon, that allows people to be forcefully medicated for the purpose of trial competency if they are deemed dangerous. So this isn't going to happen to somebody that gets a misdemeanor for trespassing. This is going to happen to the person who has some sort of very, very serious charge, and then they continue to be assaulted while in the hospital. Duty to warn. So this is where folks did some research over the week. Oregon is interesting because we have, we are considered permissive, meaning if a client tells you that they are going to hurt somebody, you are allowed to contact authorities as opposed to required to contact authorities. The reason that it is worded that way is because you're a mandated reporter, right? And mandated reporter requirements are different for different types of jobs. So a counselor, you know, and you can look at your specific, you know, if you're an LPC versus an LCSW versus an LMFT versus an MD versus a nurse, whatever, your mandatory reporting requirements change. Everyone is a mandated reporter for child abuse, elder abuse, and abuse of a disabled person. This is talking specifically about if the person is threatening to harm an able-bodied adult, right? So not child abuse, not elder abuse, and not abuse of a disabled person. So Tarasoff versus University of California. This was a school counselor, and a girl gets murdered, and her partner murdered her because, yeah, that's what happens. And the partner talked to the counselor about it, and the counselor didn't think they could do anything because of confidentiality, and then the guy murdered his girlfriend. And so the Tarasoff rule basically says that yes, you are allowed, in fact, you must warn the person if there's a clear and imminent danger. Best practice is person and police. Varies again by your type of license and your state.
So then how do you know how much you can tell, like how much can you tell the police and how much can you tell the person? I mean, talk about an awkward conversation.
Yeah, you tell the police that I have a client, here's the client's name, here's where they live. They made statements that I believe make them a clear and imminent harm to so-and-so, and then the police take care of it. Your job is to report. You are not law enforcement. Unless you get a job in law enforcement, and then that's that. But for the purposes of your degree, your job is to report.
And we don't have to say like why. I mean, you're just saying they're an imminent harm, but we don't need to give the backstory that's sufficient.
I mean, that's up to you. So they're going to ask things. They're going to ask about things like means, method, plan, in which case you probably should tell them because they're the police, right? So if they say, I'm going to go get my gun and shoot this person, you had better tell the police that they're going to do it with a gun. Right? And they have the gun and where they have the gun, all that kind of stuff. You're not going to go into detail about this client's history and their issues with their mother or their diagnosis and all of those other things. You're going to give the information that is relevant, that makes them a clear and imminent threat. Thompson versus County of Alameda. So this is basically saying like, okay, we think this person is a general threat, as opposed to, we think this person has a specific threat. So this is the difference between the kid that sat at school where you're like, wow, this guy, I'm getting mad, you know, school shooter vibes, versus the kid that actually has specific plans. You can't violate confidentiality just because you think they're a bad guy or you're getting this vibe from them. You can only violate confidentiality if they have a specific threat. So that gets icky because we see cases where somebody writes like this whole huge manifesto and maybe their counselor felt like this person's going to go out and do something, but unless they tell you and unless they have a specific threat, you can't really do anything, which is not a great feeling. And when in doubt, consult, right? Ask your boss, talk about it as a team, talk to your licensure supervisor, all of that stuff, decide, right? You have liability insurance. Talk to the people who are in charge of the liability insurance. Figure it out. Anna?
So in another class, they were talking about when you have to report child abuse. And the professor gave an example where he actually had to do that, and he told the client ahead of time, I'm going to do this, I'm going to take consults, you know. Would you do that in this case too? Or
it's up to your clinical judgment. Yeah, the question is whether or not you would tell the client. It's totally up to your clinical judgment, right? Often, what I like to do is work with the client and say, listen, this is something that I have to report. We can either do it together or I'm going to do it. How would you like to go about this? And a lot of clients, they're telling you because they're distressed, right? And they know. Part of consent to treatment is going over mandatory reporting. So anytime I have a new client, you know, we do our whole assessment and we talk about mandatory reporting, what that means. And I tell them ahead of time, if you tell me XYZ, that's something I have to report, you know? So they already know what's reportable. And you'll have clients who don't tell you things because they know it's reportable. But if they do tell you, then talk to them about it. I will absolutely have conversations with clients and say things like, listen, I'm concerned about this. This is something I have to report. Let's work through it. Yeah, because it's also, you know, that's just how, like, the NASW Code of Ethics, the first one is client right to self-determination. So you get to choose, just like you do as a parent, like, hey, we're going to the store no matter what. You get to choose whether you go in the car seat or whether or not I drag you. So same thing with clients. I'm going to give you the choice. Either we do this together or I have to do it because I'm required to. But it's totally up to you. It depends on your comfort. If you're the one you think the client's going to murder, probably wouldn't do it that way. Just depends on your comfort, your ethics, your relationship with that client, all that kind of stuff. Expert witness. So most of the time, you know, I've been to court 1,000 times. It's not nearly as scary as it sounds. Most of the time, what you're saying is, I did this assessment and I believe this person needs this level of care because that's what the assessment told me. Anybody can be subpoenaed at any time. You all already know that. The times that this gets sticky is when we do have somebody plead guilty, accept insanity, and then the person who does the evaluation, again, a licensed psychologist who's also a forensic or a certified forensic evaluator, has to do those assessments. The judge, the attorneys, they all already have the assessments. It is added to the evidence. They might be called to talk about their assessment, in which case you're just going to repeat what you already wrote. And then assessing for malingering. You will get training at your jobs if you, for any reason, if you're in a job like the state hospital where you're doing lots of legal stuff, you're going to get specific training on testifying. Yeah, you're also not going to be the only person. So let's say you are at the state hospital and you think this person has schizophrenia, the psychiatrist is the one who's actually entering that diagnosis into the system. But you consult, you know, you have a full disciplinary meeting with every patient every month where you meet with the BHS, which would be folks that have counseling LMFT degrees, the social worker, the psychiatrist, the nurse manager, the psychologist, and the patients. And you go over that person's treatment plan, and then you talk about their diagnosis, all that stuff. So it's not nearly as scary as it sounds, and it's nothing like in the movies. You have a whole team. It is part of your job to help contribute to those assessments, right? So I might write about my sessions with a client and things that we talked about, and then I might see it show up in the forensic evaluator's assessment. It'll say, but it's not just going to be my notes, hopefully. It's going to say, on this date, so-and-so met with the psychiatrist and was quoted as saying blah, blah, blah. On so-and-so on this date, was quoted, you know, met with a social worker and it was quoted as saying blah, blah, blah. And all of those things are then used in that assessment, in the documentation piece. But it's very rarely going to be just you, right? So the right to treatment. Here's another piece. This is why we don't institutionalize, because you had lots of people that were being locked up and not actually getting treatment. If we lock a person up for any reason related to mental health, whether it's civil or criminal, they have to get treatment. We don't just warehouse them away. That gets sticky, right? During COVID, we had to stop doing groups at the state hospital because we couldn't have people commingling from different units. Everything had to be individual instead. Some people were like, hey, this isn't real treatment. Lots of people have opinions. The right to the least restrictive alternatives. So this is what you will hear no matter what your setting is, which is the least restrictive environment all the time. So you get sent to the state hospital, you no longer need that level of care, you're gonna get stepped down to a lower level of care. This is also why we see folks end up on the street, because if they no longer require residential level of care, and they decline to do another type of treatment, that is their right to do the least restrictive type of treatment. This can also be insurance issues. This happens a lot. Let's say the judge says this person has an illness and they think they need treatment, but then clinically the insurance company says, screw you, we don't think they need treatment because they don't meet full criteria. Who pays for it? Things get iffy. So the right to refuse treatment on your exam and according to your book, persons cannot be forced to become competent for trial, e.g. by taking medications. In Oregon, that's not the case. We already talked about that, but for the sake of your final exam, and in a lot of states, that is not the case. In Oregon, it is only the case because we had that specific Oregon case law. And it still has very specific, they have to meet full criteria for specific types of charges and dangerousness. But in general, we can't force treatment just for competency, except for, yeah, so on and so forth. So informed consent can't just be regular. You can't just say, yes, do this. You have to actually sit down and make sure the person has capacity for consent. Patients have the right to privacy. You can't, and it's sad, right? You might have family members call the hospital and they're like, I'm really worried about my person. And you have to say, I can't confirm or deny. I can neither confirm nor deny if that person's here. Even if they know they're there, you can't unless they sign a release of info. You guys already know about privacy. The right to be treated with respect and dignity. So just because a person's mentally ill doesn't mean we're gonna do things like make them sit on a concrete block for hours as punishment. The right to be protected from physical and mental harm. The right to choose or to refuse to participate in research. The right to being anonymous in reporting study findings, so kind of all your typical informed consent stuff, and the right to safeguarding of records.
And that's just the double lock thing, right?
So with research specifically, double or triple locking is a HIPAA thing. This is about participation in research. And this could apply to any of you, not just folks that are in clinical settings.
I meant for the records, like, do those, if you're keeping those for some reason.
So HIPAA is only for treatment providers. Research is not the same as treatment. So if you're participating in a research study for some kind of treatment, as opposed to going to your doctor, right? Doctors have to double or triple lock depending on the jurisdiction. Research providers, generally, there has to be some sort of lock for records, all that kind of stuff. What this is talking about is if people are participating in a research study, like some kind of clinical trial, you have the right to decide where those records go. You don't have to, there's no sharing of records between, say, the clinical trial you're participating in with your doctor or your clinician. And then those records, let's say you participate in a clinical trial for research or for a new medication or for a new type of treatment or whatever, your personal records aren't going to be part of, it goes the other way around. Your personal records aren't going to be used in the actual study. So two-way communication there. So additional ethical issues. Evidence-based practice. We've talked about this a lot before. It is 11 o'clock, so we're going to get through these things quickly, and I'm going to limit discussion because we have a whole other section to cover after break. Evidence-based practices are considered what we do here, right? You graduate, you get a job, you use evidence-based practices in your treatment plans. How we decide what is evidence-based, the gold standard is, a double-blind placebo experiments. We've talked about EVPs a lot already. I'm not going to go over this super duper long. Any other questions about ethical or legal issues? And there's lots of stuff if you have additional specific questions about Oregon, there's lots of stuff that I posted on Canvas, including the actual legislative language that you can take a look at. Yeah. And then again, just to reiterate, your exam is going to cover what's in the book. It's not going to cover specific Oregon things. Those are just things that you should know about. So if you have questions about it, feel free to email me. But otherwise, yeah. Let's take a break. Let's do the last thing that we need to talk about is the stuff that we didn't get to last week, which is our medication-induced issues. Oh shit, my computer's gonna die. Let me plug that in. Let's do 8 minutes. Come back at 11:10 and we will talk about those diagnoses. No one's moving. Cool, come back at 11:10. And then someone in here remind me to restart recording. You guys gotta tell me these things. I'm surprised it even lasted this long. This thing's old, it's from like 2012. Switching gears completely. Other specified mental disorder due to another medical condition. There's been a few other questions about bonus points and the answer is no, because the only reason I offered bonus in the first place is because some people asked for it. I'll probably get in trouble for doing it at all. And if you're already doing well, you don't need bonus points. Life is hard, school is hard. Don't get me in trouble again. And you know, if it is one of those things where if you're already doing well, you don't need bonus points. Sorry. So we're gonna switch gears from ethical legal stuff and talk about this last category of diagnoses that are in the DSM. And these are not things that you will diagnose often as counselors, therapists, et cetera, but they are things that you should be aware of. And the reason I say you won't diagnose them often is because you're going to be working with their doctor and other people to actually do these diagnoses. This first one, this is a pretty classic example, complex partial seizures, other specified mental disorder due to complex partial seizures, dissociative type. So Savannah had asked a question earlier about whether it's, okay, I'm depressed because I'm epileptic versus do the seizures etiologically cause depression? And there is a difference. We know that there are things that happen in the brain when a person has a seizure that induces depressive symptoms. That is different from I'm depressed because of XYZ. If it's I'm depressed because of XYZ, then I'm gonna probably code an additional depression code, right? If we're doing mental disorder due to another medical condition, there has to be some kind of etiological link. You can add specifiers here because it is other specified, right? You need to add some kind of specifier. There's not a list in your DSM. Oh, you guys can see my notes, that's fun. There's not a list in the DSM, so you can pretty much add any other specifier that you've seen. If it's dissociative symptoms, depressive symptoms, you know, whatever it is, that is what you will add. You just want to make sure that it's etiologically linked to the other condition. This can also be things like, you know, adjustment disorder, which is a little different due to, say, incarceration. Those are where your V codes become really handy, assuming, again, they meet the full criteria for adjustment disorder. Unspecified, same thing, but we don't add a specifier because you don't want to, you don't know, you're too lazy to look it up, whatever. Or we just don't know yet. This person, or it could be they're having all kinds of symptoms and I don't want to list 17 specifiers. Other specified mental disorder. So again, because it's specified, we're adding specifier. These are for folks that have symptoms, but they don't meet full criteria for anything else. And the question here would be, okay, why would I not use, say, other specified depressive disorder or other specified psychotic disorder, right? The answer would be maybe it's because they're having symptoms that come from sort of a myriad of other diagnoses, right? So let's say they don't meet full criteria for any other diagnoses, but there's also not one specific direction that you want to go. You're not sure if they would really qualify for another specified depressive or other specified trauma or whatever it is. They have symptoms from multiple categories. Can also be used for things that aren't in the DSM yet. So depending on how you conceptualize things, orthorexia, right? Obsession with cleanliness of food, types of food, so on and so forth. Some people conceptualize that as an eating disorder, in which case you would add it as an other specified eating disorder. Some people conceptualize it as an OCD type disorder, in which case you would do an other specified OCD type disorder. Some people don't know and they want to list it as its own thing, in which case you would use the other specified mental disorder. Same thing with internet addiction. Like, do I conceptualize this as an other addiction type of disorder, or do I think it's something else? Sensory issues, sensory processing disorder is not a diagnosis in the DSM. So if you think that this is a person who just has sensory stuff going on, you could use another specified mental disorder. Folks have probably heard the phrase highly sensitive person. It's all over the internet. There's a couple things that could mean. It could mean that they just really want to feel special and they want everyone to know how special and sensitive they are. It could be somebody that has PTSD, so they just have a lot of hypervigilance that manifests itself as sensitivity. It could be somebody that is autistic, but maybe they've not gotten diagnosis before, or their autism presents in ways that don't meet the criteria because of gender differences, things like that. So there's all kinds of different things here that we could spend a lot of time talking about, but we won't. Essentially, you'll use this for any kind of specific reason where they just don't meet full criteria or they meet criteria across multiple categories. Unspecified. I have never seen this used ever, to be honest with you. Because if you're saying they have symptoms, but you're not specifying the symptoms, it doesn't really make sense. And it could be used in some sort of setting where you really have no idea. Let's say you're in the ER and the person's freaking out and you have exactly 30 seconds before they punch someone and then they get carted off somewhere else. And you're like, well, clearly there's a mental health issue here, but I didn't have long enough to talk to the person to figure out what it is. Was it psychosis? Was it this? Was it that? Who knows? Maybe then you might use an unspecified mental disorder. I would probably still say other specified, and I would say comma agitated type or something like that. But again, you can have your reasons and that is perfectly valid. We're going to talk now about some medication-induced movement disorders. Again, these are not things that you would necessarily diagnose because you would need to know the medical link. So you'd be working with the doctor and you'd say like, hey, I think this person has this problem. Let's look at that. So the reason they're in the DSM is because counselors, therapists, social workers are not the only people using the DSM, right? Doctors use the DSM, psychiatrists use the DSM. So these codes are in the DSM because lots of people use the DSM. You want to differentiate between, let's say you have somebody who's really, really shaky, right? You want to differentiate between the person who's really, really shaky because of their anxiety issue versus the person who's really, really shaky because they've been started on a medication that we know has an etiological link to being shaky. And that's where the caution comes in when we talk about causality. These are things that we use to talk about side effects a lot. Most side effects resolve after a couple of weeks. If they don't, and we continue to see these issues, that's typically when you'll see these diagnoses come up. You're also going to want to rule out other issues. This person is going to need, you know, a full panel, labs, all that stuff to make sure it's not due to an underlying medical cause. You also want to make sure it's not due to an underlying other mental health cause. So let's say you have somebody who's really, really, really psychotic. They get started on an antipsychotic and then we see other symptoms develop. Maybe those other symptoms were there the whole time, but they were being masked by how intense their psychosis was. So we're going to do all kinds of assessment and observation here. Let's see. Okay. We're going to watch one of these videos, but not the other because we don't have a lot of time and you can watch it on your own time, but we're also going to talk about what they all mean. in the actual slides. It's like when you're taking your exam and you have to wait like 13 seconds in between. It's ridiculous. Oh, good.
Welcome back. Oh. In this video.
No, do the thing. Where are you? Work. Yes, it does.
We'll talk about the side effect of antipsychotic medications. There are 4 main side effects that are present in all antipsychotics or any other medication that blocks the action of dopamine. Starting with acute dystonia, which occurs very quickly, usually in hours or days. This is characterized by sustained muscle contraction, and this can affect any muscle in the body. The question normally mentions a patient who is taking antipsychotic medication and his eyes are closed shut and he can't open them, or his mouth is wide open and he can't close it. The treatment for dystonia is benzotropine or first-generation antihistamines, like diphenhydramine,
AKA Benadryl.
Next, we have akathisia, which takes days to develop. It's characterized by restlessness. So the patient would be unable to sit still. They would have to keep moving around or maybe keep moving their legs. It's quite the opposite of dystonia. We treat it with 3 Bs: beta blockers, benzodiazepines, and benzotropines. If the patient is taking antipsychotics for many weeks, they can develop Parkinsonism. Because as we know, the pathophysiology behind Parkinsonism is the lack of dopamine, and antipsychotics blocks dopamine. Presentation-wise, expect a wide range of Parkinsonism symptoms, ranging from tremors to dead feet to bradykinesia, etc. In this case, we don't stop the antipsychotic medications, but instead we give the patient benzotropine or amantadine, which replenishes the brain reserve of dopamine. And if the patient is taking antipsychotic for many months, at least 6 months, they can develop tardive dyskinesia. It causes a repetitive contraction of any muscle of the body, characteristically lip smacking. We treat it with the monoamine oxidase inhibitor, vilbenzine, tetrabenzine, or clozapine. And here's a small quiz.
All right. Oh, there we go. So that's just some of the vocabulary that you're going to see with these diagnoses: dyskinesia, akathisia, blah, blah, blah. Any questions?
So
what's that?
What's the difference between the first one and the last one? Because they were both muscle contractions.
So dyskinesia is referring to any sort of sustained contraction. Tardive is referring to anything in the mouth or tongue. And the reason it has its own kind of separate diagnosis is because it is, you see it, it's a very specific issue that people develop. You probably see this if you've worked at all with older adults. You'll see folks where they can't keep their mouth open, maybe the tongue hangs, the lips smack, that sort of stuff. That's tardive dyskinesia. So as with anything, because it's common enough that it, happens, it gets its own name. Parkinsonism. So neuroleptic-induced Parkinsonism versus other medication-induced Parkinsonism. Neuroleptic is the old word that we use for antipsychotic, but we still see it in, say, pharmacological settings, certain medical settings. So in the DSM, it is still listed as neuroleptic. How do I make this big? Hey. Bam. So again, you're probably not going to be the one that diagnoses this, but you're going to see it happen. And you're going to see, if you start to notice these sorts of things, you're going to talk to the doctor, they're going to do a blood panel, they're going to do all that stuff. And you're going to see this diagnosis so you know that that's what the patient's coping with. It's also part of your job to help them figure it out, right? Like, here's this new issue that I have because of my medication. How am I going to cope with that? How is this going to affect my life? Helping them decide, you know, making decisions around medication changes, helping them decide what, you know, if they are happy with the medications they're on. You want to be really careful to stay in your scope, right? You're never going to give somebody advice about their medications, but you're going to talk to them about, you know, weighing the pros and cons, for instance, all of those things. Neuroleptic malignant syndrome. This is extremely, extremely, extremely rare, and it happens. So this can happen not just with neuroleptics, but if you take any other sort of medication where it says, if you suddenly have a fever, stop immediately, go to the doctor, right? So same thing with antipsychotics / neuroleptics. What happens here is the person has multiple elevations in body temperature. Basically, the body's internal thermoregulation system is not working. So they get raised body temperatures, they start sweating a lot, which is the diaphoresis. They have increased rigidity that doesn't respond to things that help with that. Like some of the medications, you probably see the word cogentin a lot. That's one of the most common medications we give for side effects. They have elevated creatine in the blood, and you might see some changes in mental status, like they become delirious or appear to have neurocognitive issues. Lots of people might have a little bit of brain fog, or say it takes them a while to adjust and they feel slower or stupider or whatever. That's not the same thing as having a delirium, right? Lots of medications can make people a little drowsy, not the same thing. And usually those things go away over time, or what happens is the person's actually just returning to brain fog, or they're returning to baseline, right? So they're used to being manic, or they're used to being psychotic, and all of a sudden they're normal. So they feel like they're slow, or they feel like their brain isn't working the way it normally does. And that's true, but it's also a return to baseline, as opposed to, you know, being manic and being able to stay up for a week straight doing all the things. So neuroleptic malignant syndrome, this is typically an emergency. And if you see these things, you're going to want to get that person in to get them help right away. And again, super, 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 super rare. When it does happen, get them help, because it can be fatal. Anytime your body temperature is elevated, that can be fatal, right? Once they stop the medication, the symptoms should go away, but they're going to be medically monitored at that point. This is also a reason that we do blood monitoring for certain types of antipsychotics, to prevent this from happening. So if you're on, say, something like Clozaril, you're going to be going in and getting blood work first every week, and then every 2 weeks, and then every month when you're on that medication, because they're going to monitor things like your creatine levels to make sure you're not going to develop something like this. So that's another thing that you will work, you know, a lot of the clients or patients you work with are going to ask questions about, why do I have to go get this blood work, you know? And then you have to kind of help them understand, well, it's to make sure that you're safe. Well, why am I on this medication if it could kill me? It's like, okay, well, it's not quite that, you know, it's not quite that black and white. And then you're working with them from the therapy side to help them figure out, is it worth it or not? Medication-induced acute dystonia. So this was like what the first example in the video was. This is when a muscle is contracting when it shouldn't be. Sometimes this can be things that aren't very extreme. This can be things like an eye twitch, right? Or you're just blinking a lot. This can be things like cramping, or getting like a Charlie horse while you're sleeping because the calf muscles are contracting when you don't want them to be, stuff like that. But it can also be those more extreme examples where the person, their eyes won't open, they're stuck in a certain position, that kind of stuff. Acute akathisia. So this is the opposite, right? Dyskinesia is things get stuck. Akathisia is things are moving too much. So this is the person, if you've worked in any kind of inpatient facility, you've probably seen people that just pace because they feel like they can't sit still. They might rock, they might fidget, that sort of stuff. These are things that we always tend to notice anytime a medication is just started or increased. They do tend to get better over time, or the person gets additional things to help with it. Something like cogentin, but it can also be supplements, right? Sometimes a doctor will prescribe vitamin E, fish oil, things like that to help if the person doesn't want to take another medication. Tardive dyskinesia. So specifically in the tongue or in the mouth. Much elevated risk here in older folks. Again, we've talked about if you see folks in older homes where their tongue is sort of sitting on the bottom of the mouth instead of being up against the roof, where most of us keep it kind of unconsciously, the mouth might lag open, the lips might lag, all that kind of stuff. So most of you have probably seen what this looks like without actually knowing what it was called. We also see this with folks who have used crack cocaine, specifically smoking in the past, where they start to develop paralysis of the mouth. It looks very similar. But you will see this, you know, for the purposes of our work, you will see this a lot with folks that are on, especially older antipsychotics and long-standing antipsychotic use. We don't see this a lot with the newer generation antipsychotics, but you know, the person who's been getting treatment since the 50s and they're on Thorazine and they've been on it for however long, that person, you're going to see more of this. Tardive dystonia and tardive akathisia. So again, just codes for these. The people, this is when the person continues to have issues with the mouth and tongue, even if they stop the medication or they lower the medication. They also don't tend to happen right away. This is when the person's been on the medication for a really long time and they start to experience these movement issues, whether it's dystonia or the opposite, akathisia. Medication-induced postural tremor. So this is a fine tremor as opposed to a Parkinsonian type tremor. Does everyone know the difference? Like a Parkinsonian type tremor, there's, you know, you see like hand movements more in the external limb, stuff like that. This is a much finer tremor. It's more of a vibration and less of what we would think of as, you know, a gross motor tremor. They make a point in the DSM to say what this looks like. As opposed to looking like Parkinsonism, it looks like something like anxiety, caffeine, other stimulants. So again, you'd want to roll out those other issues. You see this a lot. Lots of patients drink lots of coffee because if you're on a medication that makes you tired, you're going to drink 6 cups of coffee a day. And then you have to figure out, we see this a ton at the hospital. At the prison, coffee was like its whole, there's like a whole coffee economy. People trade coffee, people snort coffee. I've seen people do lines of coffee and I'm like, buddy, first of all, it's not effective. Like the caffeine in ground coffee doesn't really work sublingually or in the nasal passage. You have to actually drink it. So, you know, it doesn't work that way. And you want to make sure that if they have some sort of tremor, that it's actually due to the medication and not due to something like caffeine use or an underlying anxiety or something else. And that's where you're going to be working with the doctor, you're going to be doing the blood testing, all that kind of stuff. And you'll have a lot of, and the reason I say that is because you will have a lot of clients, especially in those more intense settings, who say, I don't want to take my medicine anymore because it makes me shaky or makes me tremor, it makes me this. And I'm like, is it the medicine or is it the 8 cups of coffee that you just drank? Or is it because you also didn't take your anxiety stuff? Or is it because you're anxious and we need to do some breath work? Or we need to like actually pay attention in therapy and try using the skills that I'm teaching you, all of those other things. Because a lot of times, sadly, people who aren't happy about being on medication or they're being forced to take medication for some reason, they're going to try to find ways to not be on it. And there are definitely very real side effects. And so we also want to have empathy for people that are experiencing those side effects and the distress that comes from having changes in your body that you don't want to be there, right? You're being forced to take a medication. It's got all these side effects. That sucks. Let's help you cope with that. So we're going to kind of go at it from both approaches, right? We're going to roll out all these other things, but we're also going to have that person cope with whatever they perceive to be the problem. Other medication-induced movement disorder. So basically, they are on an antipsychotic / neuroleptic. And, or no, it looks like things that happen for neuroleptic or antipsychotic, but it is due to a different type of medication. And it doesn't include any of the things above. So this is kind of your ending catch-all diagnosis, right? I've never actually seen this all in anyone's chart, but I'm sure it's in the DSM for a reason. So I'm also very fortunate that all the doctors I've worked with are very specific in how they chart things, or they take the time to, or they're in a setting where they can take the time to really tease out what the problem is. So this is probably going to be things that you again see in settings. Maybe somebody comes to the ER because they're suddenly having things happen to them when they started a medication, right? So things like that. Antidepressant discontinuation syndrome. There's some coding differences here based on whether or not it's your initial encounter versus subsequent encounters. Couple different things. Depends on the type of medication. So you have tricyclic antidepressants, SSRIs, and MAOIs are the three main types of antidepressants. Let's talk about what it looks like. So basically, the person is going through an extended withdrawal. So they've been on the medication for at least a month. The reason it's at least a month is because it takes that long for things to level off. Most antidepressants take about 2 weeks to start reaching clinical levels, and at about a month is when they stay at clinical levels. The person suddenly stops, they don't wean off. They start having symptoms within a few days. So this isn't like I'm withdrawing within a day. Some people will experience some of the symptoms immediately, but it usually takes a few days once the medication has left their system. So they're going to have sensory stuff. They might experience sensory overload. Things might feel prickly, some somatic things like nausea, cognitive or emotional experiences, like they have mood swings, they get really anxious, they might have issues with sleep. They might be really sensory hypersensitive to noise or lights. One thing that a lot of people talk about is what they refer to as the brain zaps, which is this feeling like electric jolts in the brain. This goes away over time, or it goes away if they restart their meds. Let's say they abruptly stopped because they ran out, right? That sucks, that's sad. So this isn't always a situation of, oh, you have to take meds to make this go away. It's often because people, run out or they don't have money or whatever. We don't want to just assume they stop taking their meds because they don't want to. One thing that is usually done to prevent this, let's say they do want to switch or stop that medication, they need to work, and we always tell clients this, do not change your medication unless you do it with your doctor, because it might be really miserable for you, right? So they're going to have it titrated down. Maybe they're going to titrate it down while titrating up the new medication, or maybe their doctor's going to give them like a short acting thing to help with the side effects. So let's say they're on an SSRI and they need to stop. Maybe the doctor's going to give them Xanax or another one of those short acting, very small half-life medications to help them deal with these symptoms, keep more serotonin in the system until they're fully off of it. And look at that. Animals, aren't they cute? Any questions about the medication-induced diagnoses or times when you might use medication-induced diagnoses? No one's looking at me. You're all avoiding me. There we go. That's okay. It was a lot. No, this is a really long lecture and we've been all over the place, so I totally get it. This is kind of the last week catch-all on the syllabus of like, let's talk about these two different things that are vaguely related. We could have ethical discussions about medication, right? Which we kind of already covered, and you guys did a great job of asking all those questions about that. Or ethical discussions about V codes, which you guys did an amazing job of discussing last week, which is how we ended up discussing this stuff this week. So any additional, we do have a few minutes left if anyone has additional things they want to talk about or questions, concerns.
One is about the V codes. So I heard from a friend of the therapist that they're not, insurance won't cover them.
Yep. It depends on the insurance. So the question was whether or not insurances will cover V codes. The answer is maybe, sometimes, often not. And it depends on the insurance. It depends on the person. It's also really, really frustrating because, so like, for instance, I've talked a lot about my one client who's a 12-year-old boy who there's nothing wrong with him. And so it becomes an access to care issue, and that becomes an ethical issue. Do I make up a diagnosis and slap it on this kid because he needs help dealing with some of these issues because his family is low income and has OHP, as opposed to a higher income family that could maybe come and pay out of pocket, in which case I don't need a diagnosis at all. That's crappy. That is not a good solution. So we'll figure it out. What will probably end up happening is I will use an other specified, comma, parent-child relational problem, right? That's where those diagnoses become useful, because you're saying, well, there's not really something wrong with this person, but if I need to throw something on there for insurance to pay for it, I'm not going to lie and say he has anxiety or depression or adjustment disorder. I'm going to call it another specified, and then I'm going to add the specifier that would be what I would normally put as a V code. Still doesn't feel great, but that's an access issue. And so for me and my ethics, I feel really strongly about making sure people get care regardless of their income and regardless of their socioeconomic status and all that stuff. Other people want nothing to do with it. Like, I've worked with providers who've got full private pay because they don't like the ethics of diagnoses in general. I'm not comfortable with that because I feel like, you know, not everybody can afford private pay. So it just depends on your personal, what you're comfortable with, what you want to do, you know, the folks you want to work with, that kind of stuff. So good luck. Sorry, I don't have a good answer.
Liz, how do you navigate the communication with the client around diagnoses? Is that like, I feel like that should be an open discussion that you can have with your client, and even just saying like, well, let's look at the criteria and see how this fits for you. And you might say, oh yeah, you're worried you're bipolar and you're not, or you are. Yeah. And so, but like, how would you go about, like, if they don't ask, do you not go there? Or
I usually have the conversation. So it also depends on the setting, right? So at the state hospital or at the prison, and if you're working with folks that have certain types of mental illnesses where they don't have insight, let's say the person has schizophrenia, they've been diagnosed, they very clearly meet the full criteria, but they are in complete denial because of the nature of their symptoms, right? And you are now part of that delusional framework or part of that persecutory delusion or whatever. I'm not going to stand there and be like, you have schizophrenia, because I've seen people do that and it doesn't go well. It just kind of drives the person further into their framework. I might go over the criteria with them and say, here's why you've been diagnosed and here are the specific beliefs. And let's reframe these things, right? Let's reframe this as having different beliefs as opposed to incorrect beliefs, right? People get really triggered when they see things like the word delusions on their treatment plan, stuff like that. And so we might change the wording a little bit. We might say this person has uncommon beliefs. You know, you might try to change the wording to make it more palatable for that person. But when it comes to other types of illnesses where maybe there is insights, or even people who really, really want a diagnosis that don't have one, or people who just don't understand diagnoses, like my 12-year-old is telling me that his mom's got him on like 30 medications. And I'm like, well, for what? Well, my depression. Okay, what is depression? I get sad sometimes. And so I got out the DSM and I was like, here's what depression actually is, as opposed to you get sad sometimes because you're a person and people get sad sometimes, right? Difference there. Or like if somebody thinks they're bipolar, things like that. I have a client whose mother is insistent. She's an adult client, but her mother's insistent. First, she thought she had schizophrenia, and then she thought she had bipolar and all these things. I'm like, yeah, let's go through the criteria and you tell me if you feel like you actually meet the criteria. There are other people who look at the criteria, but they don't actually understand the clinical language, right? Because they're not trained like all of you. So they'll see words that are a little bit more ambiguous, or words that are used colloquially, but that aren't the same meaning clinically. And so then it becomes your job to kind of explain to them what that means. But yeah, I would absolutely, anytime you're doing, especially in private practice, the client has to sign off on their treatment plan. So if their treatment plan says they have this diagnosis, I'm probably going to talk to them about it ahead of time. There are also clients that I might have a conversation with that I say, hey, you want to come in and see me twice a week because you have this thing that's really stressing you out. I have to make a treatment plan. Most of it's going to be bullshit, but your insurance requires it. So let's do that. And then we do it together. I mean, it just depends on that client, the setting, your relationship with them, all that kind of stuff. Savannah?
Do you see a lot of people who come in with like significant misconceptions about what the disorder even looks like? Like if they thought like, oh, you know, bipolar just means I'm happy one minute and then I'm sad the next.
Yeah. So the question was if there are people who come in with misconceptions about diagnoses. Absolutely, especially with bipolar, because lots of people think bipolar means mood swings. And so we do a lot of education around that. Like, okay, have you had a manic episode? And they're like, what's a manic episode? And I'm like, And then we talk about that. Or like I have a guy who, and it's not him, but his caregiver, who's not actually his caregiver, it's this elderly lady that he's roped into giving him free rides everywhere. He's like, she must be on her period, blah, 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 blah. She's got PMDD. And I'm like, first of all, she's 60. Unlikely. Second of all, she's not having, then she's bipolar because she got mad at me. And I'm like, that's not what bipolar is. And she's mad at you because she's tired of driving your ass here every day for free, so on and so forth. That's not actually what that conversation looks like, because I don't talk to my clients that way. I talk to you about that way. But, you know, there's definitely a misconception where this person has emotions, therefore they must have a diagnosis. And I see that a lot. Like with my 12-year-old right now, I'm really trying to work on differentiating between anxiety versus being worried about things that people get worried about, right? Like, are you actually anxious? Are you anxious about things that it makes sense to be anxious about? Or are you worried because you have a test? Are you worried because your sister is sick? Are you worried because your parents are fighting? As opposed to you have anxiety. Or like for a long time, the parents took him, I think I mentioned this before, they took him to every single doctor in town to get him ADHD medication. And everyone is like, he doesn't have ADHD. But because he gets up and he fidgets because he's a 12-year-old boy. So there's lots of, you know, nuances there. I'm like, okay, let's actually go over what that means. And with a 12-year-old, that conversation is going to look different than with a 30-year-old, right? Like, tell me about the kids in your class that have ADHD. What do they look like? Okay, do you feel that way too? Well, then probably not. Or maybe you feel that way sometimes, and that's okay. So you definitely want to do that psychoeducation piece. Other things, last minute concerns, thoughts, questions. This is our last meeting, so. Cool.
Liz, I'm curious about that 12-year-old you've talked about. And I know that we've covered a bazillion things, so it might just be me having a hard time remembering. But how do you handle it when you believe the problem is the parent? So like the mother may want the ADHD medicine because she heard that kids that have it focus and do better on testing. And she might be so anxious about the future that if he doesn't do well on testing, she's sure that catastrophe will strike. Like if the child is your client, what do you do about this set of parents that seem out of control? And we don't necessarily know that they're bad people. They just may have severe anxiety.
Fortunately, with this particular client, the whole family is being seen. So one of my colleagues is seeing mom, one of my colleagues is seeing dad. And as of last week, we now do a monthly consultation where we talk about that. And the issue is mom has very, very, very severe illness anxiety disorder, both for herself and for others. For example, when we consulted on Friday, my colleague told me that she was trying to just do some very basic somatic awareness with mom and asked mom, like, what are you feeling in your body right now? You know, how is this anxiety manifesting? And she's like, well, put my hand on my chest. Oh, I can feel my heart. Oh my God, am I having a heart attack? Like immediately went to worst case scenario, right? So the focus is going to be on helping mom deal with that stuff. And right now I have V codes down for the kid. And I need to talk to my boss about what we're going to do about that. Because on one hand, this kid comes to my office every week. He immediately rips off his mask and he gets some honey sticks and he sits down and he fiddles with my toys and we just talk about life. And that is his safe place that he gets to go and exist for an hour once a week. I don't want to take that away from him. And am I committing insurance fraud by letting him do that, right? So we'll see. It'll be a long-term issue and not a right now solution. For this one, there's a sibling relational problem because the sister is problematic. I have currently the V code I have for this kiddo is other family related problem, completely generic because there are lots of problems. And yeah, I don't know. We will see.
Is the mom on medication for anxiety?
I don't know, probably. The mom's not my client. I'm biased against mom. If mom were my client, my attitude would be about her would be totally different, but mom's not my client, kid's my client. So my job is to advocate for kiddo. If she's not, she needs to be. Because I feel like if you're going to drug your 12-year-old, you should also, But yeah, I have no idea. That's a great question.
That's what I've diagnosed her with, anxiety. And I feel like by helping her, we help him. And I'm worried about your 12-year-old.
I'm very worried about my 12-year-old. We're very worried about this whole family. The other piece is that there's a lot of personality stuff with both parents, and distress tolerance stuff, and just teaching skills, right? You can't teach your kid distress tolerance skills if you have no distress tolerance skills, right? You can't model distress tolerance skills if you don't have distress tolerance skills. So a lot of it is like, okay, the very basic is just learning somatic awareness. Because how do you know that you're distressed unless you can actually be present in your body without dissociating because of how intense that distress is? So we're starting very, very basic, right? I can't get you into DBT to teach you distress tolerance until we first know what distress even looks like, or what we're going to call it, or what it feels like in your body. So we're going to start really, really small and go from there. So it is 11:49. I'm going to let you all go. Yeah, I agree. I share the concern for my 12-year-old. It makes me sad, but that is the work that we've all signed up for. So there are happy cases too. I just don't talk about the happy cases in class because they're, you know, not super relevant to what the things that we're talking about, or at least not as much. I do have one happy case. My DUI guy has been in recovery from alcohol and cannabis since he got his DUI in December, and he's applying for lots of jobs, and he has broken up with his awful, awful girlfriend. So good things happen in therapy, but they're not interesting for educational purposes. All right, have a lovely week. If you didn't get your accommodations on your exam for timeliness, etc., let me know. I'm pretty sure they're all there, but if not, let me know. And Godspeed.
Thanks so much, Liz.
All right, bye.